you very much. On to speak. Those participating by phone, please keep the phone on mute at all times unless called upon to speak, and do not put the phone on hold. Please avoid using the speakerphone. When speaking, please speak directly into your device's microphone or your telephone receiver. I'm now going to ask the board secretary to conduct the roll call, please.
Certainly. Member Banham? Member Banham? Yes, thank you. Member Cloutier?
Présent.
Merci. Councillor Chanteri?
Present.
Member Gower?
Here.
Member Kavanaugh?
Present.
Member Lakin?
Present.
Member Menard?
Here.
Member Pinel?
Présent.
Member Tilley?
Present.
Vice Chair Di Giovanni?
Present.
And Chair Egley?
Present.
You
And
have quorum, Mr. Chair.
thank you. I must commend Member Lakin on his background. Sitting outside. Hopefully we won't go too late and he's sitting in the dark, but we'll do our best. So we've received no regrets this morning, or this afternoon rather. I'm going to explain the meeting procedure again because we are doing this via Zoom. So the following procedural guidelines are being implemented to promote orderly proceedings of this virtual meeting. Attendance, should members need to leave the meeting, they should advise verbally that they're doing so before clicking on leave the meeting from the Zoom platform or ending their call if participating by phone. The speaking order and the process for speaking will be as follows. I'll provide each member with an opportunity to ask questions or comments. Members will be called on to speak in the order set out in the board secretary's voting list. The usual 5-minute limit will apply. Should you not wish to speak on any given matter, you may decline verbally when your name is called. Voting, if a full recorded vote is not taken for a given item, I will specifically ask if the item is carried and then call for dissents to ensure that all votes are properly registered. Any points of order, privilege, or challenges, procedural interjection should be kept to a minimum to ensure the meeting proceeds smoothly and to minimize confusion. For points of order where you have not been called upon to speak, please state your name aloud for the record before stating your point of order. Should technical difficulties or other unforeseen matters require a recess during the course of the meeting, unless the board secretary issues new instructions, members are requested to remain on the line, so to speak, and the board secretary will mute all participants in such an instance. Are there any declarations of interest tonight? Okay, thank you. Can we confirm the minutes of the meeting of June the 15th, 2020, please?
Carried.
Thank you.
Confirmed.
Any dissents? Okay, thank you. We have received 12 communication items have been received, and we'll receive those communications as noted in the agenda. Received?
Received.
Thank you. I'm going to ask Member Cloutier will move the motion to introduce reports, please.
Merci, Monsieur le Président. Thank you. Il est résolu que la présentation par Cameron Love au nom du comité d'intervention de Champlain COVID-19 sur le partenariat et la préparation, le rapport verbal du président du conseil de santé, le rapport verbal de la médecin en chef en santé publique et les rapports intitulés Update on COVID-19 and Next Steps, Ottawa Public Health Strategic Plan for 2019 to 2022, Year 1 Refresh, 2020 Operating Budget Q2, Board of Health for the City of Ottawa Health Unit Status Report, and the delegation of authority contracts awarded for the period January 1st to June 30th, 2020 be received and considered.
Carried?
Carried.
Carried.
Any dissent?
Carried.
Okay, thank you. We'll now go through a usual consent agenda process. For those participating or watching from home who may not be familiar with this process, I will list each item on the agenda, and for any items where board members don't have any questions or concerns, and we don't have public delegations registered to speak, the board may carry or receive those items on consent, which is to say, without any discussion. So firstly, we have Cameron Love will be appearing on behalf of the Champlain COVID-19 Response Committee, or as we like to call it, CRIC. He will give a presentation on partnership and readiness. So we'll be holding that for the presentation, and we have one public delegation listed. Number 2 is the Chair of the Board of Health verbal report. We'll hold that. 3 is the Medical Officer of Health verbal report. We'll also hold that. 5 is Ottawa Public Health Strategic Plan for 2019-2022, Year 1 refresh. Can we receive that? Okay, received. Thank you.
Received.
I'm going to ask Deanne Blade. Deanne, it was we should receive this as opposed to carrying it.
No, we need to carry that, Chair,
Oh, I'm sorry. Okay.
because there is an approved.
Okay, carried then. Sorry for that earlier. Carried.
Carried.
Any
Carried.
dissents?
Carried.
Okay, thank you. Thank you, Deanne. And number 4 is update on COVID-19 and, oh, sorry, I missed that. Number 4 was update on COVID-19 and next steps, and we're holding that because we have a presentation on that one. Number 6 is the 2020 operating budget Q2 Board of Health for the City of Ottawa Health Unit status report. We have a motion to amend the report, which we can do now through the Vice Chair if there are no other reasons to hold this report. Okay, I don't see anybody wishing to hold the report for questions. So Vice Chair, can I ask you to introduce the motion to amend?
Sure. Whereas capital projects and the corresponding new capital spending authority, therefore, be it resolved that the report titled 2020 Operating Budget Q2 Board of Health for the City of Ottawa Health Unit Status Report be amended by the following, by adding the following recommendation. That the Board of Health for the City of Ottawa Health Unit approve the establishment of 2 new capital projects for seniors dental clinics and new capital spending authority totaling $2,092,600, which will be 100% provincially funded.
Thank you very much, Vice Chair. Can we carry that motion, or are there any questions, comments?
Carried.
Carried. Any dissents?
Carried.
Can we then carry the report itself as amended?
Carried.
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 Any dissents? Nope, seeing none, thank you. And finally, number 7 on the agenda is delegation of authority contracts awarded for the period of January 1st to June 30th, 2020. Can we carry that?
Carried.
Carried.
Thank you. Any dissents? Thank you. So we will go back to the first item on our agenda, which is a presentation by Mr. Love on behalf of the Champlain COVID-19 Response Committee. And thank you for coming out tonight, Cameron. I can tell you that your presentation and your presence have been eagerly anticipated. There are a lot of questions out there around where we are specifically on the testing issue as schools have opened and we're entering fall and we're in stage 3 and all those other things. So we look forward to your presentation, and then I'm certain there will be questions to follow from the various board members and So we will turn it over to you. I think we can share the screen with you. There we go, Cameron. And I will leave you to run your report for us then in your presentation. Thank you.
Great. Thanks very much, Councillor Egley. Can you hear me okay?
Yes.
Yeah, you can hear me fine. Okay, so thank you for that introduction. I'm Cameron Love. I'm the president and CEO of the Ottawa Hospital, but it's a pleasure to be here this evening to talk to you in my capacity as co-chair of the Champlain COVID Response Committee, which, and I'm going to give you a bit of an overview in terms of how we've responded as a region. And I think there's some important context to set in terms of all the things that are happening within the healthcare system. So maybe just a little bit about this pandemic to start. I think many of you have been in this community for a long period of time. I myself have been here for close to 25 years working at the Ottawa Hospital, and ever since it merged in 1998. And I think the real challenge, and all of us have been through many disasters, whether it's tornadoes, ice storms, the shooting on the Hill, bus crashes, train accidents, all of them. And all of those ones have a very prescriptive approach that we take as a healthcare system to respond and manage, and they're typically short in duration. I think the biggest challenge that we've had on this one is, one, the duration is extremely long, and the ability to forecast what's coming next and how long we're going to be in this creates a significant challenge in terms of the pace by which we're responding as a community and how we manage through that. And to that end, I really want to thank Dr. Etches in Public Health. I mean, from the beginning, we've had a very close working relationship with all the partners, but particularly Vera and the public health team have been tremendous in terms of providing leadership, not only for the Ottawa community, but what's happening regionally and provincially. And so I'm going to walk through a little bit of a snapshot of where we've come from and where we're going. So I'm not sure who's controlling this. Maybe next slide, please. Oh, perfect. Okay, so I think what's really important to understand here is, while we have a community response, a lot of what we have done since we started back in February has been driven by a provincial and a regional command structure. And right from the very beginning, in around February, March timeframe, as the pandemic really broke, and particularly with all the concern and heightened anxiety of what was happening in New York, there was a very prescriptive provincial incident command structure, one that was set up regionally. And then through the regions, each major city was asked to create a structure that would link into these regional and then provincial command structures. So in our eastern region, there is one regional structure, and it's run by Renato DeCenzo. And we've got a command structure in Ottawa, Kingston, Peterborough, Lake Ridge, and then the Scarborough areas. And those are the structures that all come together within Eastern region. And typically most of the direction has been coming through that structure in terms of how communities are to respond and then how we report up. Next slide, please. And I think the other really important thing, and Vera commented this at the beginning, there's not one partner that can actually manage this pandemic successfully. It takes really an entire community on how we band together. And I've listed some of them here, but obviously Dr. Etches and the whole public health team, we've had community health centers, primary care, all the hospitals stretching from Barry's Bay down through to Hawkesbury, all the way over to Cornwall as one sort of regional response across 18 centers. Peter Kelly and the paramedics group has been absolutely tremendous, and also working with what's happening in the East and West with those paramedic divisions. All of home care has been dramatically impacted in terms of how we provide care to those that are in a home so they don't have to actually be transferred to hospital. And then a myriad of various community agencies, physiotherapy clinics, everything in between that has been impacted from the very beginning, and how we start to ramp up and resume back a service profile. Next slide, please. So when we started this, and I think this is very important context, because I know while testing is extremely important, the health of the population is equally important in terms of how we manage access to healthcare. And so when we started this in February, there was a tremendous amount of concern that we were going to experience what New York experienced. And so at the time, coming out of the province through to, again, to the region, and to mainly focused on the hospitals at that time, but it also included home care, was how do we create capacity that if we have to ventilate, let's say 300 COVID patients in hospital, and we've got another 400 that are COVID positive, how do we create capacity within this region to manage that within hospitals? And that was the really first major exercise. And so in about a course of about 3 weeks, we ended up creating a whole new structure for critical care. There were ventilators that were brought in. We created temporary setups. This is a time when the government issued the directions to ramp down all elective activity. So we canceled, to give you a sense, we do about 50,000 procedures roughly in the Ottawa hospital. We were doing about 15% of that. So a dramatic ramp down with an indication that we may end up having to ramp up hundreds of COVID patients into hospital. And so we had a regional response in terms of managing hospital care. At the same time, a tremendous amount of effort around PPE. It was probably one of the most tense components of whether we had enough PPE. And I think one of the underpinnings for all of us involved with this is how do we create environments where our staff and our care personnel are 100% safe? And so that whole PPE and supply chain management was a very bumpy start in terms of concerns around running out of PPE. If we run out of PPE, do we have to shut down services? And so that occupied pretty much the bulk of Feb and March. And then at the same time, a direction provincially and regionally out of Ministry, Ontario Health, all public health agencies, in terms of how as a province, a region, and a cities across the board, are we going to start to create a testing strategy or testing capacity? And back then, when we closed down surgical activity, we had lots of personnel that could help. And that's when Brewer opened, the MOFOR opened a site, Queensway was starting to open a site. And over the course of 2 months about, we started to create the first wave of testing capacity, albeit at a time where there was still lots of discussion on who should be tested, when they should be tested. And the main thing was to have testing capacity in hospitals, because if we were going to have a couple of hundred COVID patients, we had to create a model that allowed for that testing to occur. Next slide, please. So as we got into April, what became very clear, and I think a lot of this had to do with public health's sort of information and response to the community in terms of social distancing and all the rules and the regulations. And I think Ottawa as a community, we responded quite well when you look across the province. So what we didn't see lots of people coming back into hospital. We had a peak of somewhere around 30, 35 COVID patients at the Ottawa hospital, probably 10 to 15 at Queensway, a few at MOFOR, and then less as you get into the outlying regions in the Pembroke, Cornwall area. But what we did start to see was tremendous concern around what was happening in long-term care. So I'm sure many of you recall there was about 6 or 8 sites that were considered as red. There was probably 30 to 50 across the province in the same concern in terms of large numbers of COVID positive patients. So at that time, what ended up happening was the staff that were supporting various aspects of either testing or staff that we were using in inpatients or services that we had ramped down. We also deployed huge portions of staff into the long-term care setting to make sure 2 things. First and foremost, that the quality of care and the patients were receiving safe care, and we had proper protocols for infection control and how we managed those environments. 1, because we wanted to make sure that we controlled the spread, but 2, as well, as that bed capacity is generally a problem across the province of Ontario, and it's a particular problem within Ottawa. So the thought of losing 5, 6, 8, 10 long-term care homes and having all those patients transferred to hospital was not something that would be in the best interest of health for this region. So a huge amount of effort. Again, a lot of directions issued at the Ministry of Long-Term Care. Vera's team did a tremendous job in terms of monitoring the status of where these homes were at, and then based on directions between the Ministry of Health, Ontario Health, and Public Health, across all public health branches across this region, hospitals' capability to be able to respond, to go in and help them. By then, though, thankfully, we had stabilized the PPE. We had a much better supply chain, and so we were actually providing huge portions of PPE into about 20 or 30 homes across the region, and had a much more stable supply chain associated with PPE. And then again, ongoing testing and discussions, particularly around lab capacity, not around assessments and swabbing, more around, we have 2 major labs. There's the big one, obviously, within the public health infrastructure across Ontario and the public health labs. And then we have an Eastern Ontario lab, which basically services just the hospitals. And the question is could we grow capacity? What was public health's lab infrastructure doing to grow? And what was the expectation in terms of growing capacity within IRLA to allow, for the Eastern Ontario Regional Lab to allow test turnaround times to continue at the same rate of somewhere between 24 and 48 hours. And at that time, it was generally stable. Next slide, please. So as we moved into the summer, what we started to see was the long-term care sector was fairly stabilized, and we had hundreds of people involved with that in terms of managing it. We had pretty much stabilized all homes. There was a monitoring process put in place, but what started to become a significant concern was access to surgical care. So things like endoscopy, getting CTs and MRIs, and definitely access to surgical services across the board. What we started to see was patients coming into the hospitals where, because they weren't getting their scheduled surgery, they were acutely ill and needed urgent surgery. So we ended up having to bring everybody back into the organizations, particularly Queensway, Montfort, TUH, Cornwall, and Pembroke, that are the major surgical centers, because what we started to see is significant impacts in terms of morbidity and health of the population if we didn't start to resume this elective activity. And you saw through the province, again, a direction around directions coming out from the province through the regions to requesting hospitals to now start to ramp back up our surgical activity. As we started to do that through June and into the summer, what ended up happening is the occupancy pressures that were there pre-COVID started to occur again. So since about probably July, most hospitals have been running pretty close to 100% occupancy, if not greater. We've had to put in surge plans, and part of it is that one is the ramping back up of surgical services, which is absolutely critical from the health of the population. But on top of that, what we started to see is a number of people that decided that they wouldn't come to hospital when the COVID first hit. The acuity of their illness had grown, and so by default, the number of ambulance transfers and number of people coming to hospital started to increase. And so now we're at a state where we've got significant pressure in terms of bedded capacity and creating surge plans to try and open up probably close to another 200 beds just to deal with non-COVID acute activity for this community, which is absolutely critical to maintain. And so to that extent, huge pressure in terms of bringing back large portions of skilled staff. So when we started, we were sending, neurosurgical OR nurses to do testing. Well, now that we're having to do more and more tumor surgeries because the demand in incidence disease, all those staff have to come back to actually support the hospital, or we're going to have significant issues in terms of the health of the neuroscience population. As an example, same thing with cancer. And all of our major surgeries, whether it's thoracic or vascular disease, cardiac disease, all of them have started to rise back up again. And so part of as we headed into June to September is not only were there challenges in terms of how do we support long-term care, how do we consider testing, but most importantly, how do we staff the hospitals so that we actually don't have a significant healthcare issue in terms of access to healthcare. There's been groups starting to work about how do we create a bigger resource base within Ottawa for healthcare. You saw what Quebec had done as a provincial response in hiring PSWs to support long-term care. That wasn't done here in Ontario, but having said that, there are still lots of work being done in terms of what are the various sectors that we can go out and hire more and more staff. So we've been changing models of care. We've been looking at how we can use staff in different ways to make sure we cover the emerge, we deal with all the inpatients, we deal with all of access to surgery, and we deal with particularly those who require urgent care, while making sure that long-term care homes also provide care safely and effectively, and we don't compromise care in those buildings. And then the same thing, ongoing discussions around how do we continue to build testing and lab capacity, and lots of work, which I'll talk about in a second around that. So that brings us up to September. Next slide, please. And as we look to the fall, there are a couple things within the overall healthcare response, which I think is a very important context. We are backlogged. If we don't do anything, it'll probably take us years to catch up on the surgical backlog. And so there is an active discussion happening again with the ministry and the regions around, can you grow your surgical activity by 20-30%? A lot of our wait time targets we are not hitting that were set by the province. We have very long wait times for things like MRI, access to critical services, joint replacements. We're just opening the Riverside this week. This will be the first time we've done cataract surgery, except for those that are urgent, since February. And so we are in the process of trying to grow that activity because there are a number of patients that need quicker access to surgical care that are either one, have been waiting literally months and months, and two, their conditions have reached a point that if we don't provide those access to those surgical services, their condition will worsen dramatically. And so we're opening the entire Riverside. Almost all ORs should be open over the course of the next week to 2 weeks. And we've had to ramp up and surge up trying to find additional staff to do that. Same thing on the surge and transitional bed capacity. Working with ministry in the province and the region is how do we open additional beds? So we've got Greystone, which is a retirement home on Main Street, that we've got a partnership with that operator that will be opening 120 beds as we head into October, November, which will be tremendously helpful. But we probably need in the range of 2 to 250 to get through the winter without having to scale down service or overload our emerge departments. So a lot of work around growing that surge capacity and coming up with a human resource plan, because that activity has to be staffed by things like RNs, definitely physicians, specialists, PTs, OTs, speech language pathologists. And so we're in the process of how do we ramp up that beyond what we would traditionally run. As well, we are now back into a second phase where there are some long-term care homes that are starting to struggle. Obviously, the one that is top of mind for everyone is West End Villa. Again, the hospitals are now responding to how do we help these homes manage so that we contain any outbreaks. Working closely with Vera's team, the hospitals, can we use community care resources to pull so that the long-term care homes, we actually make sure that they continue to provide safe care and we provide access for families and those types of things. So we're working with 2 homes at the moment between West End Villa and Laurier, and then monitoring closely. Vera's team monitors closely in terms of the outbreak statuses in the other homes, and then depending on the direction through public health and Ontario Health, if we're requested, then the hospitals have to determine how we can potentially respond to support the homes. Again, health human resource planning, probably occupying a huge portion of the provincial time. I can tell you whether it's Ottawa, London, the GTA, Toronto, Kingston, and Ottawa, health human resource planning is the core to what everybody's trying to figure out is how we grow healthcare resources in this community quickly, which is not easy. You can take things like OR nurses to give you a sense. To get a fully functioning OR nurse to do things like neurosurgical or cancer surgery, you're about 6 months of training. So to create them quickly is not an option. That's why they have to be in the OR operations. Same thing with emerge nurses, trauma nurses. Those type of resources have to be within the hospital. The question is if the hospital's resources are all here, what other labor pools can we work with collectively as a community across all those bodies I said at the beginning to band together to figure out how we deal with the less acute areas and support expansion, whether it's testing, whether it's long-term care. How do we use paramedics? Peter Kelly and Tony DeMonte have been tremendous in the last few weeks of really trying to rally around. Can we pull anybody that is classified as a paramedic to help test and or help in long-term care? And so a huge amount of effort in terms of going into West End Villa to support that population that was upwards of 40 plus COVID positive patients in a 240 bed home, which is a real significant concern. So over the winter months, as we head into the fall, definitely September, October, November, those 4 bullets are probably the focus of what we're all doing regionally, and definitely what the focus is of the province and the direction they're giving out through to the regions. And we're probably going to be into a tighter incident command structure provincially, particularly with long-term care and the congregate care support to make sure those patients have the supports as required, because they shouldn't be transferred to hospital. But if there is no other option, then transferring to hospital just creates greater challenges in terms of how we manage the healthcare system as a region. I think that might be it. Next slide. Oh, I think that's it. So yeah, that was it. Thank you. So I want to close by, I know I've given you a lot of information as a snapshot, and hopefully it's been helpful. What I really want to close by is these if pandemics and these types of things, we haven't done this in 100 years, and many of us obviously weren't there for the first one. But while we've had H1 and N1 and we've had SARS in the past, they are nothing like this, and it's tremendously challenging to deal with all the various elements and prioritize how you manage access to healthcare. But I got to tell you, as a region, one of the most refreshing things that I found, and I really want to thank all the healthcare partners, from your chief of neurosurgery down to housekeepers across every organization, all the city staff, Vera staff, community health centers, home care. People are really rallying, trying to figure out how we grow capacity in this region. I think that's the key to this, is how as a region and a community do we grow access to healthcare without compromising the overall health of the population. And it's hard. It's not an easy curve. And I think that's the only way we're going to get through this, is if we continue on that direction to everybody working together. So maybe I'll stop there, Councillor Egley, and I'm happy to take questions. Hopefully that's provided a bit of context in terms of what we're doing in the healthcare sector, and we'll happy to take any comments.
Thank you very much. We do have one public delegation, so we'll go to the public delegation before we go to board members for questions and comments. So most of you will know this public delegate. It's our colleague from council, Councillor Suds. So Jana, can you hear us?
I can indeed.
Okay, so you have 5 minutes now. Unlike your normal role, you have to present as opposed to asking questions. So
Yes.
I'll turn it over to you for 5 minutes.
Fantastic, and thank you for the reminder. I appreciate that, because you're right, typically it would be questions. But I appreciate the time, and thank you very much, Cameron, for the presentation tonight. Certainly very thorough in giving us the whole picture of some of the challenges that you, your team, and many of the partners that you've mentioned continue to face. I wanted to speak tonight specifically around two topics. The first being testing. And, it's my understanding, as you've referred to, I think the Champlain COVID Response Committee, CRIC, I'll use that acronym if I may. It's my understanding that the province has appointed the hospitals as the lead for testing in Ottawa. And so I'm assuming that my questions are best directed at you, Cameron, based on your capacity with CRIC. So I'm sure it comes as no surprise that after having the pop-up testing center here on the weekend at the Canadian Tire Centre, that it really demonstrated the demand for that service. And so I have concerns moving forward, whether we have the capacity to meet that demand. Obviously, I'm speaking for the West End, but I think the same can be said across the city. So ensuring that we can work collaboratively, I think the use of the surge capacity, I think it was referred to you, that came in with paramedics from across the province, was certainly an effective tactic. But I would certainly support many of the initiatives that you mentioned as well, Cameron, around increasing our capacity and our staff levels here within the city as well, and ramping people up. So that is, for me, a big concern, is that capacity and increasing that capacity to meet the demand across the city, but specifically in the West End. The other item is, as we're seeing at the Coventry location for the drive-through site, I think it's important, given the lengthy lines and waits that people are having to go through, that we do move to an appointment-based system, so that people have some certainty around what they can expect when they're going to one of our centers for testing. And then I think lastly, the other item I wanted to mention briefly, as it came up in a few discussions I had today, is around communications. And, in my capacity, I'm privy to a slew of, really outstanding communication products put out by Ottawa Public Health and the city as well. Admittedly, I don't see as much from the hospitals at this point anyways, but that could be my blinders. But I think when it comes to testing that there is currently a bit of a communication void that I would like to see the hospitals via CRIC fill. So right now, obviously Ottawa Public Health has locations for people to go be tested at on their website, but I view that as more of a CRIC or a hospital responsibility to be amping up those communications. As new sites are added, as capacity is added. I think the pop-up site at Canadian Tire this weekend is a great example where I personally don't feel like the communications were as I would have hoped, if I may. So taking a look at what that communication strategy is, who is the lead, and laying out what that plan is with respect to the testing centers. And I'll leave it at that. A big thanks again, Cameron, for being here for the presentation and for all of the outstanding work in supporting our city through this. Thank you.
So thank you, Jenna. Now, for my colleagues on the board, both councillors and members, this is a once in a lifetime opportunity. We don't usually get to ask questions of council members. So as Councillor Suds was a presenter, if anybody has any questions to ask her, I see Councillor Kavanaugh.
Yeah, this is too much fun. Thank you, Councillor Suds, for raising that issue. I thought I was the only one who was caught off guard with the opening of the Canadian Tire Centre, and we're never going to argue about having another testing centre, but it was just that it was not known ahead of time. Perhaps that was the strategy, but I would like to know if when she received that communication as well, and what the response she received was in her area.
Sure, happy to answer the question, Councillor Kavanaugh. I received an email, I believe it was around 10 a.m. on Saturday morning from the paramedic chief, Peter Kelly. I, as well as my colleagues, it's Councillor Gower's ward, as well as Councillor El Shantiri. I think it was just the three of us on that chain letting us know. My comment with respect to communications is, without being too direct, there was hesitation for us to be sharing that information. Because as it was communicated to us, it was for referrals from the Brewer Centre once they reached capacity, which, it quickly got out in the media, and there was communications coming from the hospital that were not in keeping with that. So, that's one of my comments with respect to communications, is to try and streamline that, and who's taking the lead, who's following, and where do we point residents?
Yeah, no, I hear you. And I got it a little later, and it was suggested I share it, the communications with the, on Saturday morning. I did do it, but it was also that feeling that I felt like I was going to create an avalanche. And I was a little concerned about that. And it certainly was busy. Can't argue against another testing site. It's just the fact that it was hard to know what to do with it, if it was meant for just that area or if we were overloading the system. So that was my concern, and I didn't know how others felt about it. So thank you for sharing that.
Thank you, Member Kavanaugh. Are there any other questions for the delegation? Okay, seeing none, thank you very much, Councillor Suds, for making time to join us tonight. We're now going to move to questions from board members. I'm going to start off, and then we will move in the order of the voting list, and I'll run through it at that point. So Cameron, again, thank you for coming out tonight. It's appreciated. As I said when I introduced you, there's a real interest in CRIC's role as the lead in this, and the hospital's role as the lead in the response to COVID, especially around the testing piece. So I'm sure most, if not all, members will have some questions for you. We've heard and we know that there are a significant number of people showing up at all the testing sites that are asymptomatic or have not been referred by a health professional. And I've heard anywhere from 50% and upwards of people in line fall into those categories. I'm wondering what steps CRIC is taking to triage that, to make sure that the people who have symptoms or have been referred by medical professionals are getting served as they should get served, and people without symptoms are being prioritized in a different way or being given a different message. Because part of the backlog, I think, at all the sites is the fact that people are showing up when they are not exhibiting any kind of symptoms. So I wonder if you could speak to what CRIC's strategy is going to be to deal with that going forward.
So I think we need to clarify something key here. So the hospitals are not leading testing. When this was set up initially by the province through the medical officer of health, it was channeled down through the medical officer of health, through the regions to public health agencies in terms of direction of who gets tested and who doesn't test it. The hospitals don't make that decision. What the hospitals do is the hospitals respond to a direction set by Ontario Health with the public health agencies, and we have to rally around to providing support. So the Canadian Tire Centre was not done by the hospitals. I think it's a really important piece around how do we create, and I agree with Councillor Suds, I think we're going to have to reset a structure here in terms of all the various intakes. But to your question around who gets tested and who doesn't get tested, I might ask Dr. X just to comment on that, because that direction comes out of the public health agencies and the province. And then the regional response is who can actually provide support. So the hospital.
I understand that, Cameron. The question I was asking, though, and Dr. Etches is going to give us an update later, and I'm sure that question will come up. But what I'm asking, and I was referring to CRIC, not the hospitals in particular, but CRIC, which is the governing agency, if you will. What is there any thought to polling people, asking people, finding out as they're in line why they're there, how they got there, whether they're exhibiting symptoms, to have those discussions with people, or to do some sort of pre-screening, if you will. So that's where I'm going.
Yeah, so I think that's a fair comment, Councillor Egley. I think part of this is moving to an appointment scheduling system that can eliminate the wait times. If people have appointments that they can show up. Your question is around who should or shouldn't get tested and how we inform the community. And maybe I'll let Dr. Etches comment on that.
Yeah, I can speak to that, certainly. So I agree with Cameron Love that the policy we're following is set provincially. So that's decided at the provincial level. And I think it's like we collaborate on the ground here in Ottawa between healthcare and public health. I believe it's also a collaboration at the provincial level. There's public health discussions, healthcare discussions about the policy of who should be tested. So what we know is that the policy is that anybody who wants a test should be able to access a test. And we know that is straining the system. And so my local advice as we try to deal with a system that has limited capacity is to use the tests in the best way possible. So where they'll be the most helpful. For example, when people have symptoms, to make sure that it isn't COVID, when we're trying to control an outbreak or find out what's happening in a school. Those are public health referrals for testing. And so, it's my advice that we do prioritize those people. And it may be that we'll have to get to an operation that does take a look at, how people in line are prioritized. I believe operationally that is often done. So we we work together in terms of I provide advice and recommendations, and then the operations, I believe they are trying to say, if you have symptoms, come this way, we'll see you more quickly. I believe that is the case.
Okay, thank you for both of you for that answer. Now, Cameron, you referred to moving towards an appointment system, and right now, correct me if I'm wrong, we only have an appointment system at one location. Can you give us a timeline as to when you think CRIC will be able to implement appointment testing at all the locations?
I can't comment on all of them, but I can definitely say Coventry's up and running. We're trying to move to Brewer next, and then trying to get the Queensway Montfort sites onto that over the coming weeks. I think the first one that we will have moved to is Brewer, with appointment scheduling over the course of the next week, give or take a day or two. And then we've got to take a look from a systems perspective, what can be done on the Montfort and Queensway sites. And that'll help, but I do want to stress what Vera said. I think part of what we have to do is make sure we're triaging those who absolutely need to be tested, because there's the capacity of the assessment centers, and then there's the turnaround time. And if you look what's happened in Alberta, I think the turnaround time is now about 7 days. So we have to be able to grow both the lab and the capacity. So we're doing both, and the province has just approved a whole series of approvals around additional machines for public health labs and our lab in Ottawa. And part of that is buying the machines and getting them set up to run. And so part of this is staging that increase. And while we stage that increase, how do you triage people based on the greatest need? Appointment scheduling will help, but then there's also communication that we've got to put together collectively with Vera around how do we inform the public of who should or shouldn't be tested. And I think the real piece that is equally as important is how we align that with the education system, because a lot of the testing is related to if you have a sick child and now I can't work, but I'm asymptomatic. There's a piece that we have to get clarification on. That's why I'm saying it's driven predominantly out of the province and Ontario Health, because those directions are not even set locally at times, they're set provincially.
Right. So I appreciate that, and you sort of answered the next question I was going to ask you, is about what are your plans to avoid long lineups outdoors over the winter, and you seem to be saying you're moving within weeks to an appointment system at as many locations as you can. So that should help address that. So thank you for that. Building on what Councillor Sudd said and what I've heard from some of my colleagues about the communications piece, and people are sometimes confused about which location they should be going to and when the locations are open. And for example, the first tweet that I saw about the CTC said open for 2 days, and it said today open until 6 o'clock, but didn't say anything about when it was open on Sunday. So I was having people saying, well, do we show up at noon like people showed up today, or can we be there at 9 o'clock, or how does that work? So as CRIC kind of manages the sites, and staffs the sites and what have you, I'm wondering, has any thought been given to a single website which would list all of the sites, the times they would be open, all those sorts of things that people practically want to know, at a one-stop shop, so there'd be a consistent message about where, how, and when you could get tested. It wouldn't have to be a pretty site, wouldn't have to be a fancy site. People just want the information. So has there been any thought to putting it all on one page, and then the makes the messaging easier for counselors and other people? Just say, you got to go here. That's going to tell you the where, the when, the how. So has any thought been given to that?
I would, if I was a betting person, I said you would have been on the call with us earlier today. That's exactly what was discussed. I think two pieces was, one, we've got to get a website, but two, we've got to, so we met with city staff today around where, like, we don't own any physical buildings as CRIC. Where are the possible buildings that we can go next? So this is what I mean by regional response. So the city is in the process of looking at alternate locations, not only for where we expand, but to your point, Councillor Egley, is where do we, if we have to bring them inside for the winter, where do we bring them inside? And so they're doing a scan to say, okay, we can do X, Y, and Z for locations. What we need to do is communicate it to the public that here are all the locations, and here's the ramp up time that it's going to take to get there. So everyone understands what it is and the timing to get there. And then as we get changes there to the provincial government through Ontario Health, most likely into public health officers around who should be tested, who shouldn't be tested, how it links with the education system, then we're probably going to end up making adjustments through the fall. But to your point, if we can put out and say, okay, here are all the sites, here's where they're located, here are the times in operation, it's an automatic booking system, and this is how many are done a day, and you can expect to wait X period of time, then at least it's transparent in terms of communicating to the public, this is what we've got. And then you just kind of try and manage that through that as almost like an incident command. But I think the key thing is going to be is some of the changing directions on who should or shouldn't be tested, which we've always worked with Dr. Etches on, and that quite honestly for Dr. Etches is getting direction out of Ontario Health in the province. And so part of this is expanding this to bring the province and the regional group on to what happens locally, because we're not setting the direction for that. So the pop-ups is not something that was done, it was done provincially. Same thing, there may be discussions around what's happening with pharmacies next, what are we doing with primary care next? So we've got to have a tighter conduit that we're going to pull in over the next week to make sure we've got all those pieces wrapped together. And then the website is exactly what Vera and a few of us had talked about over the last couple of days to try and get up and running.
So do you have a sense of a timeline on a website, Cameron?
It's not months, it's not weeks. It's, you know what, we're going to try and get something out where we can get some type of scorecard to people that gives that information over the course of the next week.
Perfect. No, I think that would be very helpful. And the last question, staffing is an issue. We know that. We've heard that before. Can you give us a sense of what qualifications are necessary simply for the purposes of doing the swab test? You've talked about the necessity of having nurses in surgery and an emergency. So, I mean, I even saw something on social media. I don't know if it's right. I don't know if it's wrong. Over the last couple of days, it said that flight attendants who currently aren't working all that much are trained as first responders and could be allowed to carry.
And it becomes a little bit more challenging because when you get into the pediatric population, you don't want someone that isn't able to swab a 3-year-old that doesn't have that clinical expertise or as a regulated health professional be able to do it. Now it's different with adults, but you still need it to be under a delegated license. So there are a series of positions, but what you can't do is you can't take, you know, to your point, you couldn't take a flight attendant, train them up and say, okay, you know what, we're going to get you to swab, because the swab it goes quite deep in terms of it, and it's based on the regulations. You have to have certain classifications to do that role.
And I did say last question, but just one quick one out based on what you just said, and that is the testing that's become available in Alberta, which is a sip and gargle and spit approach, which doesn't require swabbing. Is that something that CRIC is looking at or in discussions with the province over? Because I assume that's something that could be administered by a wider base of people. Again, there's no swabbing, what have you. Has there been any discussion about looking at alternative testing to the swab test?
So that's not something CRIC would look at, but Vera, do you want to, I don't have any knowledge on that. That usually comes out of the province for us.
Yeah, our experts on the testing strategy when it comes to the actual tests, we usually look to Public Health Ontario, the lab experts there. We do have lab experts in Ottawa, so the ERLA lab and the Public Health lab, and they do help us, assess if we could try something different. So there's interest for sure around how can you collect the specimen more easily. We see that with children; it would be wonderful. There's other questions that are laboratory questions about can you pool the samples so that you have more capacity to put samples through with the existing machines. And I really don't have answers in terms of where we're at in Ontario, but I do know they're being examined.
Okay, thank you for that. I'm going to move to the list now, and the first member on the list is, and if you don't have questions, simply indicate you don't have questions, but I suspect most of you do. The first person on the list is Member Benham.
Hi, thank you. You had to leave some questions for the rest of us, Chair Eglai. First of all, I just wanted to say thank you on a personal level. As your role as CEO and president, my daughter was born April 3rd in the beginning of the pandemic, 8 weeks early in quite an emergency fashion, and she spent 40 days in the NICU at the Civic. So thank you for all the help. We received wonderful care, and even though it was quite scary to enter a hospital every single day when they were saying do not enter a hospital, the staff were wonderful and they did their best and they made us feel safe. So I just want to say thank you on behalf of myself and Aria. And then in terms of my day job, when I'm not being a mom, I run the Ottawa Birth and Wellness Center, which is a midwife-led center. And I bring this up because last year we hosted a there's a birth center where babies are born, and then on, not mine, but we also have a community center on the other side. And last year we hosted a flu vaccine clinic. And I can only imagine that CRIC is starting to think about what the flu season, which would typically be public health busy season, what that flu season is going to mean for testing for staff, etc. This is a big overlay between public health and hospitals, who see a lot of people who come through the ER. And I'm just wondering if conversations are bringing people in within the community to start looking at how we're going to communicate the difference between the flu and COVID, what messaging might need to go out, but also what kind of partners are going to come in to help with hopefully keeping people out of the hospital so that we're not adding to the already burdened system.
Vera, do you want to take the first one and I'll take the second?
I think it's probably, I have more in my verbal update about our influenza strategy, Member Banham, so I'm happy to describe that a bit more fully later, but we absolutely are planning to try to immunize a much higher percentage of the population, and it isn't CRIC that's trying to mount the immunization response. It's actually our usual partners, so pharmacies, primary care, and public health, and with some, I'll speak to a few more pieces. So CRIC is still an emergency response structure related, focused on COVID. And then of course, influenza will create more complexity and more burden. So in terms of when it comes to the hospital pieces that Cameron mentioned, it just adds to the strain. And the testing, burden when people have influenza, it is actually pretty difficult to distinguish. So the public health role will certainly be to try to communicate what's happening to the public with influenza in our community and to help people understand when they should go for testing, whether it's COVID, flu, or both, how they would do that. And, it's again, unprecedented territory, but it will be a partnership across all of those players. I'm not sure if that answered all of your questions, but I do have more to say about flu in a bit later.
So maybe I can just add to that, Councillor Banham. I think, pre-COVID, if you just forget COVID for a second, the months between December and March are always the busiest time for hospitals. And it's typically related to flu, but it's not necessarily the flu itself, particularly for the elderly population. It's getting flu and the exacerbation of chronic diseases that they have that bring them to hospital. So part of our challenge is making sure we ramp up enough bed capacity, because there will be the elderly that have chronic respiratory illnesses, COPD, those types of things, that when they get the flu, they get transferred from long-term care, et cetera. We get them stabilized and transfer them back. So part of this is how do we support LTC? How do we continue to support home care? Because it's that population when the flu hits. Like I have 3 boys. If my kids get flu, well, typically they're on the couch, and you know what? That's generally it. You take the elderly population that gets the flu that's even being provided home care, the exacerbation of what they get is quite severe, and that's why you see so many people come into hospital. So to Vera's point, part of this is getting that campaign started, and then how do we have a surge response to manage should flu hit. Now, I'll make a comment and Vera can jump in. I could be dead wrong in this, but my personal belief, seeing some of the data out of Australia, is hopefully the masks and use of masks is going to help with flu to some extent. There's no real evidence of it. Vera can comment far better than I can, but people wearing masks and trying to not only contain the spread of COVID, it probably will help to some extent with the spread of flu.
Any other questions, Dr. Banham?
No, I think that's it. Just a pitch to remember that midwives are also regulated care professionals and may be called upon, as I feel like
if you
I
guys
say almost every
are
meeting.
willing to swab, we got lots of room.
I'll talk to them about that.
Member Cloutier, please.
Thank you, Chair Cameron. It's nice to see you again. Nice to exchange with you again. I'm sorry about these circumstances, but it certainly is a privilege to host the Ottawa Hospital in Alta Vista on Smythe Street, and many frontline workers, our constituents, and my sincere thanks go out to you and to your team and for what you're doing for our community. I guess, like any medical procedure, there's a need, but there's not infinite capacity to provide testing. There's logistics, there's staff, the expertise of staff, and we talked a little bit about it. What is our current test capacity per day, if you want, here in Ottawa, and what is the demand?
So I'll take a stab at this, Vera, and then jump in. But if you discount the Canadian Tire Center that occurred on the weekend, I think we're give or take a couple hundred and around 3,000. Is that about right, Vera? 3,000 assessments in the, sorry, 3,000. When you say, I think there's two pieces to this, Councillor Cloutier. One is our capacity to swab, and one is our capacity to test. The testing capacity with the labs is give or take a couple hundred, around 3,000 to 3,200, I believe, is what we're sitting at now. Part of this is how do we grow that capacity to 4,500, 5, and then 6,000, and the same on the assessment center side. So we're kind of in about the halfway point of where we predict we need to be from the most recent data that I saw. Is that about right, Vera?
Yes, I would agree that it's both the capacity to take the swabs and the capacity in the lab where the plans are to double. So what we know is right now the lab capacity is just not quite keeping up with the swabs being taken. And so that's where you start to see the turnaround times lengthen if swabs have to be sent out of the region for processing. So it's pretty close. The estimate we've made from a public health perspective about children that need to be swabbed because they have a respiratory symptom is about 2,000 children a day. So that's a lot of our capacity right there. And we haven't seen that yet. We don't have 2,000 children a day coming forward. So, this is just the beginning of the fall. We were estimating in usual respiratory virus season what we might see.
So am I understanding, Dr. Etches and Cameron, that we need to up capacity to 6,000, you said a number, I think 6,000, and 1/3 of that, 2,000 approximately, would be children. Is that about?
That's our estimate at this time. I think we continue to learn, and that's based on the existing policies from the province about who should be tested. So certainly, if the policies change around who should be tested, what's the indication for testing, then those numbers would shift.
And that number 6,000, that is the current COVID cases and the expected second wave. That's our best estimate at this time, that this will provide the results, the testing needs for the expected second wave?
I think that That's overstating it. I don't think we know, right? Because the second wave or the peak that we're in right now, or, you know, the rise we're in right now, we want that to be as low as possible. So it does depend on all of our actions, what capacity is needed. So as I say, this current estimate is based on the idea that anyone who wants a test, based on historical patterns of people accessing, and then the additional pressures from schools and the fall virus season. But I can't say that that's exactly what's needed. It's not something you know, that Cameron said at the beginning we can predict with certainty. So we're monitoring what the actual demand is from children against what we estimated. We'll be looking to see if we can get community transmission back under more control with fewer cases a day. That will make a big difference in being able to meet the demand. And so would any policy change at the provincial level. You know, that would shift the ability to meet the demand as well.
And I recognize that. I recognize it's difficult to predict, and the current policy, you referred to the current policy, Dr. Etches and Cameron. What can we do to better communicate the objectives and the reasons for testing, as well as the time to test? I understand that some people, some patients attend a testing center the day after perhaps an event where there might have been transmission, or a risky event, an event where there were a lot of people. How can we communicate better to ensure that the resources are best used, that the test is meaningful and productive for the person and for our community in terms of our capacity to deliver those tests?
Well, I certainly appreciate if you can share the messages from Ottawa Public Health. And the simplest way we put it, which we're trying to share more and more clearly, is that the times when testing is recommended are when you have symptoms of a respiratory illness or public health has referred you. And we understand that people are anxious and want a COVID test in other situations. We get that. People want to know, they want to check, they want to make sure something happened, could I have been exposed? The problem is that you might get tested when you're still incubating the virus and it won't be detected because you haven't got a high enough level for the test to detect it. Or you might get tested, think, oh goodness, phew, it was negative, I don't have the virus, I'm good to go. And that's the wrong message, because you might actually come into contact with the virus then if your behaviors are too relaxed. It's actually our behaviors that protect us. So I'm trying to counsel people, if you're anxious about, you know, thinking you need to get a test, then to think about your actions that might be putting you at risk and stop doing the things that might be putting you at risk. That way, you know, it's actually, we have lots of evidence now. It's actually very unlikely that you will get COVID if you stay 2 meters away from other people and you wear a mask indoors. So that's the protection that people can use to feel more confident. But I know, you know, it's a tough one, and so you know, if you can just give the simple message first, and then that emphasizes the priority, and then we can accommodate others as the system allows.
And absolutely, the hospitals and OPH have been consistent not to get tested unless you have symptoms or directed by a healthcare practitioner, and just the basics, then wear a mask, 2 meters, and stay home if you're sick. That's been the consistent message. Are we seeing people getting tested more than once and for no apparent reason? Cameron or Dr. Etches?
I'm sure that happens, and I don't want to blame any individuals. You know, there are reasons why people need to be tested more than once. You know what? I'm going to even use my family, right? So I have a little child who's in school now, and you know, he's in the age group where it's hard to wear masks all the time. He's got a respiratory symptom. I've taken him to Brewer. We've lined up, you know, to get the time when you come back for the swab, and we come back at the right time. It happens, right? So it's not useful to blame people, and that might happen again. And you know, people have jobs where they need to be tested because of exposures, and that might happen regularly. So there are reasons. um, you know, I think that each circumstance is going to be different. And so, you know, it's certainly, I think, you know, something we want to continue to examine. So I think the suggestion was made earlier about talking to people in line, you know, learning from people. Why are you here? What can we do to support you in terms of understanding what's the best action for you at this time? You know, I think these are all things we can keep trying new ways to understand what's driving some of the testing. And so I look forward to working with CRIC, you know, to use the information they can gain from the operations to inform the communication.
Noted. And my last question, Chair, conversely, is there a particular population that our testing efforts, our testing information, communication are not reaching, and how to reach them, be they language barriers or other barriers? What can we do to ensure that we are reaching all segments of our population that might need to be tested?
This is a top priority for the Ottawa Health Team, and it's another new entity that is trying to find its way of contributing to the pandemic. Ottawa Hospital is part of that, so is public health. Community health centers are taking the lead on this very question because they have community developers in communities where the language barriers might exist, the cultural barriers. There's a need to translate, to adapt materials and messages. And there is a significant focus on how to make sure people know about how to prevent COVID transmission, and then access testing if needed. And this is where we do see the Ottawa Health Team with leadership from community health centers is actually going to be another avenue of testing, access to testing for people who do face more barriers. So this is actively underway, and an additional support, as you say, for populations who might need it.
Dr. Etches, thank you. Cameron, thank you very much for the information this evening and for the presentation and your work in our community. Thank you, Chair.
Thank you. Vice Chair, please.
I never know whether you're going to call on me in alphabetical order, Keith, or right before.
I just do whatever Deanne tells me to do, and this is the list she gave me tonight.
So yes, thank you, Cameron, for your presentation. I will say the cooperation amongst the partners are pretty phenomenal. We do talk about silos in healthcare, but really everybody has really just come together. The only thing I might add would be that just like the adults, certainly with my youth hat on and my kids hat on, just like the adult pressure for supporting long-term care, for increasing testing, for occupancy, acuity, and ramping up elective surgery, it's the same for children and youth. Some would argue that the pressures can be even higher because of the developmental milestones. I feel like I'm caught up from the CRIC perspective though, so I would have no other questions for Cameron.
Thank you very much. Member El Chantiri, please.
Well, let me begin by thanking you, Dr. Etches. First of all, today is the anniversary of the Dunrobin tornadoes, and it'll be remiss if I don't mention your staff, your public health nurses working on the ground with our community during and after the tornado. So it's heartfelt thank you to you and your staff for job well done. Mr. Love, I'm sure you heard from my colleague, Genocide. I represent West Carleton Marsh. That's the far west part of the city. It's mostly, all of it rural, basically. My area larger than the city of Calgary by 50 square kilometers. And I'm glad I heard your explanation about the pop-up happened at the Canadian Tire Center. to say the least, was confused to the average resident. That's understatement, because residents start calling us, why you're not promoting this, why you're not telling us this is happening, to the fact we knew it's happening, but we were told not to advertise it because it's not, it's just for the overflow from the Queensway Hospital. But I'm glad you clarified it, but we need to do a better job, Mr. Love, because again, the resident don't make a difference if this is the responsibility of Ottawa Hospital, Ottawa Public Health, paramedic, all what they know, there was a pop-up for testing and we were not informed about it. And that's really is hard. I had asked before, and I know our public health staff and paramedic been asked about to have a mobile testing for the rural area. As you heard, our resident is not been allowed to test in Renfrew. So even the folks who's next door to Arnprior or Renfrew County, they cannot be tested there. They have to come to the Ottawa. That's what we're told time and time again. Unfortunately, Lanark County is different. Lanark will accept, Almont Hospital will accept our resident. So when I saw that our area didn't have any cases, while I know that's not the true assessment, obviously my resident didn't have a chance to be tested. And some of them, they have a mobility issue because we don't have even public transit from Fitzroy, Kinburn, Galata area, all the further area to go to the city. So I'm hoping you still consider a mobile testing for the resident, the older adult who's have a challenge to go to those sites. Even if it's Canadian Tire Center, it's still almost 45 minutes from the further corner of the west of the city to get to the Canadian Tire Center. Brewery is almost an hour drive, and the list goes on. So I'm hoping you still consider a mobile testing unit to address some of those community on the far end of the city to be able to get that service. My other question is, if you are creating the website for folks to go and get the information from you, will it be possible to enter the postal code? So residents, they can enter their postal code. This way, the postal code will direct them which area they should go to. So the person who lives in Galata should not go to Mountford Hospital, perhaps better to go to Queensway or Brewery or other. So I hope you can consider that as a postal code to help manage the expectation. And as far as communication, you heard from my colleague, both Kavanaugh and Sud, we need a communication. We need a communication strategy. I always use the analogy when I used to own a retail business, parents would bring their children and ask, would you like some ice cream? I never heard a child say, no, I don't want ice cream. So when we do, let's everybody testing without the mechanism in place or the first wave, that's creating, and especially when we heard half the people showing to those test sites, they shouldn't be there to begin with. So I hope we can streamline those areas and help us in a rural area with the communication, and perhaps in your capacity, if you can speak to the Minister of Health, why Renfrew, who's been mostly covered by the Minister of Health for the testing, deny those residents on the edge of Renfrew County, they're denying the testing.
So all very good comments, Councillor. Let me try and take these. So your postal code access, I can take back. As we set up this, as the team is looking at how to set up automation and the discussions we had with Ontario Health today, we can take that one back for sure. I don't disagree on communication. Actually, I do have a question for yourself or for the other councillors. Notwithstanding everything that we've talked about, if through Ontario Health and the whole regional team, we put out a communication on the website that outlines where the facilities are going to be, the timeline they come up, the amount of expected activity that can be done, do you think that the community can get behind, even though there will be a wait time associated with it? Because it's going to take weeks to grow that capacity. If we give you that information, does that give you enough to reassure your residents that here's the plan, here's what's coming, and we're moving in that direction.
We've seen it happen, Mr. Love, before when we have the N1.
H1N1, yeah.
And so resident obviously showed up and they were greeted by someone, take their name and give them a bracelet and say, just come back after 4 and you come back after 5. Your group come back after 6. And first come, first serve, but also they managed the expectations. So people didn't have to wait outside. They didn't have to wait in the weather element, but they have to go home and come back. But that testing, Mr. Love, happened locally. So they were in their own community. So people in constant space stay in constant space. People in CARP stay in CARP. But now people are praising the element. They're going to those testing only to be turned away after they drove an hour, tried to find a parking. And I don't have to tell you, you're hearing all about this. So it has to be a better way to manage the lineup and manage also who should be tested. And I know we drill on this, and I know some residents showing up, and we heard from Dr. Atchett saying, we don't want to blame people who are nervous about the test. But I mean, if it can be managed, because the weather is changed, and to read a list, I represent 30,000 people in West Carleton. To look at the map and say 0 cases in it, what would that tell you? That tells you there's no testing been done from this area.
So I'm happy to take it back. I can tell you unequivocally, between Tony DeMonte and Peter Kelly, they are supportive of ramping up to try and do more testing if they can hire more paramedics. Because I think that as I've looked at this, it's kind of the same with hospitals in terms of how we're providing access to hospital care. This has to be multi-pronged. There is not one solution that fits the entire region. It just doesn't. So, what's happening in the downtown core may be completely different than what should happen for the Kinburn residents. So whether it's drive-throughs, pop-ups, mobile testing, assessment centers that can put through 5, 6, 7,000 people a day, and then some unique aspects, as Tammy said, in terms of how we get access for kids, because it is different than putting a 45-year-old through versus a 3-month-old or a 3-year-old is 2 totally different things. So part of this is that the overall regional team is looking at it. We're into a bit of catch up now. To Vera's point, if the regulations change, we may not have a testing capacity issue, but you can't bank on that yet because you don't know what's coming down the road. So we just got to keep building in that direction.
Well, thank you very much, Mr. Love, for your presentation this evening. Our suggestion, and Dr. Atchett, please relate to your staff a heartfelt thank you on the 2nd anniversary of the tornado. Really appreciate it. Thank you.
Thank you.
Thank you very much, Member El Shantiri. Member Gower, please.
Thank you, Mr. Chair, and thank you, Cameron, for the presentation. It's a really useful glimpse into, I guess, the administration of healthcare in our area and all of the different levers that you have to consider when you're making decisions. And I want to preface what I'm asking. I don't think any of us here are looking for I don't know, blame or looking back so much as we're looking forward. We're all in a good position as counselors or as community leaders to connect people together, to help you find resources and to help find solutions. I wanted you said something earlier, either in response to Councillor Sudds or to Chair Eglai. And I think you said hospitals are not leading testing. And I'm still a little bit confused over who is leading testing in our community. Can you clarify, did I hear that statement correctly? And if I did, can you clarify who is leading testing in Ottawa?
So maybe I can comment, and then Vera, if you want to jump in. We're talking about setting up an incident command that will have all the regional partners around it to run testing. Across the province, testing has been channeled down through the directions of what happens through the Chief Medical Officer of Health, down through Ontario Health, down into the regions. So when you talk about leading testing in terms of decisions, in terms of policy direction and strategies, that is a lot of that comes out of the province and the Ontario Health. In terms of being able to respond to manage that, Vera obviously provides that input in terms of policies, practices. What do we do with education, kids? Do we swab asymptomatic, non-asymptomatic? But that's fed through the province. What we have is the hospitals are not leading it. as you've heard, we've got a group of all healthcare providers that we need an incident command that allows a response to providing testing. So in the downtown core, if the CHCs can ramp up, they're going to lead to an extent for their area, swabbing those that are in those populations in the downtown core. The paramedics are responsible for doing almost all mobile testing. The Ottawa Hospital runs Brewer, Queensway runs the West End, MoFor is going to run the East End. So there's a laundry list of people, and then if the government directs that all, I'm going to make this up, but if all asymptomatic patients should go to private pharmacies and they're going to ramp up private pharmacies, that's not a hospital decision. That's a direction that's coming regionally. So part of this is there's not one body that runs testing. What we're doing is, and we had a discussion today on this, is we need an incident command that provides all that information through to Vera so she can inform what's Ontario Health and provincially, and a pipeline back end. So we need a lead from Ontario Health in our committee. And then you've got all those bodies around the table. So we actually have like an incident command to run this.
So that was my next question. You guys talked about membership on the committee. So on CRIC, who sits around that table for CRIC right now?
So the CCRC, which was initially set up initially to deal with hospital response for hospital services, all the things I talked about in phase 1 and phase 2. It was never set up to run necessarily testing, but over time what's evolved is it was never set up to run long-term care either. And we're not running long-term care. It's not what it's providing is it's providing a structure that brings some of this resource together to support these areas that are problematic. So right now we're into 2 long-term care homes. Through discussions with Vera, if we've got 4 others that are problematic, then that CCRC will pull on any resource that we have within there. Testing has really mounted up. And to be quite honest with you, testing in the summer was not a tremendous challenge. I mean, I think you'll all recall, we did not have long lineups. But now that we've got a whole different direction on what's happening with school kids that's coming out of the provincial direction and the public health sectors, we've got to rally around that. So we're going to probably create a different incident command structure that'll have a mixed bag between public health, community health centers, the city of Ottawa for represent ambulance services, and then a couple of the key hospital leads. And that's Ottawa. In the east and west, the public health officers lead the entire direction as well, but Hawkesbury supports them for the east, Pembroke supporting it, and Arnprior hospitals for the west. So it's very much a community response.
So am I understanding correctly, the current governance structure of CRIC is probably not adequate to respond, but there are changes being made so it's better, it's more versatile, or it can respond effectively?
Yeah.
Okay.
Correct.
And ultimately, CRIC, or whatever this evolved governance structure would be, reports to Ontario Health. Is that correct?
Correct. Yeah.
Okay.
And there's one of these, and I will tell you, I think you'll also see whether it gets publicly acknowledged or not, as we get into the second wave, if long-term care starts to become a major issue across the province will set up an incident command that'll also provide direction.
Okay.
So I think the challenge with this, Councillor Gower, is it's not something that you can sit down and map out what this is going to look like for the next 8 months. What it requires is some flexibility around all partners of how we respond. Because if we have 28 long-term care homes in Ottawa, let's be dramatic about this. If 18 of them are a problem, we've got to get a group around the table that are going to rally how we manage that. If 2 are a problem, but we can't get access to surgery for cancer patients, then we got to rally around that. So it's something that you've got to have a team that's going to ebb and flow. But the direction of what comes out of that in terms of policy is typically through public health, and then we all rally around to support Vera in terms of that direction.
I'm really concerned about the left hand not knowing what the right hand is doing. Like, I've heard little bits and pieces here. For example, you said, or we've heard from the province, they're likely going to try to roll out some kind of testing at pharmacies. At the same time, we've heard today that the capacity, the number of tests we probably need to be able to do per day in Ottawa is 6,000, and we're at about half that now. And as a hospital administrator, I'm trying to figure out, how do you possibly plan your resourcing if you don't know necessarily what the province is going to drop in? I mean, you could be, if you know those pharmacies are going to be able to handle 1,000 tests per day, that drastically changes the resourcing you need to do. So, like, is there the right communication happening between the different groups so that you actually know what you have to plan for in the next 6 months and 12 months?
So I can tell you from a hospital, if you're asking me just as the CEO of TOH,
Yes, yeah.
I can tell you unequivocally, if I pull everybody back, we have more than enough resource to manage what we need to do from a hospital perspective.
Yeah.
From a community response perspective, that's where you've got a provincial incident command, you've got these regional bodies, and then you've got local bodies that we have to band together around. And that's where you've got this CCRC that dovetails, and people like Tony DeMonte are on it. So we've got the city resource in there, and then Vera's on it. So we get the public health direction in terms of what to do. I think that the challenge the whole way through this, and there's no one to fault in this, is the communication is very quick. It's the evolution of how quickly and rapidly it changes. And so, part of what comes out of the province to Ontario Health to the regions, it's almost every couple of weeks we're updating against it. So we know we have, as an example, we have a massive backlog on surgery. I suspect over the course of the next month or two, we were going to be having a discussion coming out of the province on, for the health of Ontario, how do we catch up on the backlog of surgery? So that'll direction will come out of the province. It comes through the region right in locally. Kingston has the same structure, Peterborough, Scarborough, GTA, London, Hamilton, etc. Everybody's got the same structure in terms of responding. And I can tell you, Ottawa is no different than the rest of the province around how we're structured. It's just you've got to get a group that's going to band together. And the piece that we just have to tighten up a little bit more here is how do we create an incident command that rallies around Vera and the other Ontario health leads so that we tighten up the communication. And I think that's a key theme to this. And I can't disagree at all with that. There needs to be a tighter plan that's put out. But I think that's also not only putting out the plan, it's the timelines as to when we can achieve some of these pieces.
So I think on a positive point, I think we saw the pop-up center, the drive-through center, Canadian Tire. As I understand it, there were 2,750 patients who were seen over 2 days, which is about a quarter of that capacity if you're looking for 6,000 a day. So achieving that capacity isn't out of reach. As I understand it, there were about 20 paramedics who were brought in from Eastern Ontario. So it's a very achievable target that we're trying to meet. One last question, I guess, would be around we talked about the wait times and the online booking. It's a real problem right now, as you know. I don't know if you measure the wait times, but I heard today that people who went in with a child with a runny nose were waiting 6 or 7 hours from arrival till test. Very professional staff, but that's a long time to wait. What is the roadblock for getting this online booking? The city, it's a very different scale, but the city got online booking for swim lanes very, very quickly. So how come it's taking so long to get online booking for all of the sites? What's the barrier to that?
It's more the system in terms of registering. Remember, it is a healthcare act in essence. So they've got to be registered. It's got to be documented. It's like a health record. It's no different than when you come into the hospital. You have to be registered, and you have to have an account or you have to be registered almost like a health record. And there's got to be delegated acts as a medical directive. It's not, it is a medically delegated act, which means it's got to follow a certain series of things. So we have Epic that we've rolled out at Coventry. We're going to roll it out at Brewer. Queensway and Mulfort also have base plate systems with Meditech. Some of it is just organizing the system to be able to roll it out into those centers. So it's not months of work, it's weeks. But now that we're moving to automation, I think it'll help with the lineup. But the catch is, as well as we have to continue to grow capacity, because if you've got 2,000 waiting and only 1,000 can get into the system, then you got to communicate to people when they can't get into the system. What do you do?
Yeah.
And so that's the other piece of this that is part of this regional planning team that has to put together the entire plan. And I think it was Councillor Egley that said this. If we can get a plan out there to the community, at least we can communicate what the plan is, where the city's planning on opening other sites, which bodies will be able to staff them, what are the paramedics going to do both for mobile units, and we communicate that regionally as sort of an entire pandemic response. And then at least the community knows. Then it becomes a discussion of how quickly can we get staff and machines to actually keep the turnaround testing the same. Because in any scenario, turning around tests, if you're a bone marrow transplant patient versus an asymptomatic person, I think you would agree with me that you want the bone marrow transplant patient tested. So we're going to end up prioritizing turnaround. If we don't grow the capacity in parallel, we'll get everybody swabbed, but then it's a communication around, it may be a 6-day turnaround time, just like Alberta's facing. And as we go month by month, we can close the gaps, but it just takes time to lay out the plan and strategy.
Okay, very last question, and very quickly. it seems like the strategy is to distribute testing more. I would say right now we kind of have a big box strategy for testing, large centers, many people per day. Whereas I think you're moving towards more of a corner store strategy, closer local doctors, local community centers, perhaps pharmacy. Is that accurate? Do you see both coexisting? Do you see more of a distributed? Where do you see that going in Ottawa the next few months?
Vera, do you want to comment on that one?
Well, I think the advice and the recommendations that Ottawa Public Health is putting forward to operate the system include continuing to have big boxes because that's most efficient without the lineup. So scheduling enough capacity, 7 days a week, 12 hours a day, that kind of thing. But yes, there would be other points of access. So the more the better. So public health has been advising primary care providers to do their part, working with the Ottawa Health team and CHC to do their part. Yes, we hear pharmacies maybe coming from the province, so this would help. And I do appreciate the efforts being made to try to bring this all into one point of access, information, accountability. This will make a difference.
Okay, thank you to both of you and all of your teams for your efforts. Thank you, Mr. Chair.
Thank you, Member Gower. Member Kavanaugh, please. Oh, before we go to you, Member Kavanaugh, actually, we're getting very close to, I think, 7 o'clock. We still have Member Kavanaugh, Lakin, Menard, Cannell, and Tilley. And that's just the first round. People may want to go back on the list. So I was wondering if Deanne, if you could share the motion to extend time with the Vice Chair, and we could put that on the table and vote on that. Oh, sorry. Member Kuche would be moving it tonight. So do you have the motion in front of you, Member Kuche?
Yes, I do, Chair. Ready to go.
If you could move that, please.
Be it resolved that the Board of Health approve that the meeting time be extended past 7 p.m. pursuant to subsection 81.8.1c of the procedural bylaw.
And carried? No dissents? Thank you very much. Sorry about that, Member Kavanaugh. We'll turn it over to you now.
I find it significant that it's right before I speak. So what does that mean? Thank you very much. Dr. Love, thank you very much for your presentation and all your work of running a hospital system. You just above and beyond the pandemic, it's no doubt a challenge in these days, just trying to deal with everything. You only have to go to a hospital and see how hard they work and what is still needed beyond COVID. The everyday incidents that people require a hospital for, and it's quite the strain. You mentioned about the effects of the long-term care and what strain it put on the resources of just coping with this pandemic. And no doubt that was pretty scary times. They still are, actually. I was quite aware of the one in my ward, Carlingview, where over 60 deaths of residents, just absolutely frightening. And I remain concerned because I don't see any changes really in the day-to-day efforts that, and when you're talking about an incident command, just for long-term care, can you elaborate on that? Because I think we all want to know what's being done differently to prevent these disasters.
So maybe I'll comment just generally of where we came from and where we are now, and then Vera, you might want to comment on what we're doing around monitoring and long-term care. So long-term care is something when we started was not part of the initial response, but then when we had those initial outbreaks, we had pulled it in terms of how we respond to this. And I think the difference with long-term care is they're all run by individual corporations. So you got 28 homes, places like Extended Care, Rivera, Sienna, they may run multiple ones, and then you have individual corporations that run others. So the reality is the oversight and what happens in that with long-term care is governed and managed by the Ministry of Long-Term Care with their inspection branches. So I think Vera's team, and correct me if I'm wrong here, Vera, manages sort of status of outbreaks and cases that may occur. The long-term care branch has an oversight function of what they do for all homes in Ontario. But then if we get homes that get into trouble with outbreaks, then this is where Vera raises them, and we all have to, figure out how we're going to support that home. And I do want to make a comment, because I don't want to make it sound like the hospitals are coming to the rescue on these things. There are some tremendously dedicated people within those long-term care homes, the staff and the physicians that operate in there. And, it's when you get a home that gets into trouble where they've got 10, 20, 15, whatever it may be, positive cases, part of what we're really trying to do is not only make sure the care of what the patients receive is as strong as it was pre-COVID, but also support the staff in there. There's a huge element of educating and supporting the staff. They don't deal with infectious diseases like Vera and my team would. They just don't. It's not inherently how they're trained. And so part of this is getting in there as early as possible to provide that IPAC support, provide that education. We're not taking over and running the home. The extended cares of the world still run the home. It's a support structure we put into it. So ours is very much one of taking direction out of the Ministry of Long-Term Care. And then if Vera's team through monitoring has concern, then we bring hospitals, home care agencies we're also talking to now in terms of how they can support with staffing so that we rally around a home. And that's in essence what happened the first time around. It was very difficult, but I think quite successful. But to your last comment, Councillor Kavanagh, when we left and the Ministry of Long-Term Care put this in place, they put an evaluation and education toolkit together to give to the homes to say, these are the 10 things you should be focusing on since the summer. And what our hope is that those homes have put those things in place, and they're actually more stable than what they were during the first wave. But that's the whole point of having a monitoring process, that if we do get word that it's not going well, then we've got to rally around it. Because I think for me, if it was my mother or father in one of those homes, you want this controlled as quickly as possible.
I appreciate it, and I hope things improve in terms of the standards when they go through their commission, and perhaps you can give them some advice during that commission, because you certainly have hands-on experience in this. We were talking about the communication, as some of my colleagues have talked about, and just getting information out. I think probably one of the best communications I've ever seen is Ottawa Public Health itself, who are excellent at getting information out. And you were talking about setting up a website, but and I apologize, Dr. Etches, but your team is so fantastic. I think, is there any way they could collaborate to assist on that? You have the top communications people who really get information out.
Yeah, all of this work has been a collaboration, and absolutely those conversations are already underway about how collectively we could add information into a joint site so it's all one place for everyone.
I appreciate it, because I think people just instinctively go to OPH for information. You just, mind you, most people Google and it'll pop up. And so in terms of don't reinvent the wheel, if it can be done with what's happening already, because I think there's a lot of good ways to get information out, not to mention the 23 communication channels you have here with counselors who are constantly getting information out to people, like we did even on a Saturday morning. I was sitting there seeing a message pop up we weren't expecting, but we got it out. If we thought it was important, we would. So one of the things that's happening in British Columbia, I'm sure you're aware of, is that the runny noses for kids, things that are going off the list. You can't help but wonder that the long lineups are related to kids going back to school, and the concern that school boards have. I know this is not your decision making, but I'd like your opinion on that, because it's been implementing in BC, and would that make a difference? Because clearly anybody who's had a kid knows that they can have a gazillion things, but we're all trying to be careful, but it's about reducing some things off the list if if it's an issue.
Yes,
Anyway,
I think, I mean, I can comment on that one, probably can't. Okay, it definitely made me interested to hear that they would be in BC taking runny noses off the list. Other things like headache, because I don't know how you can rule out that that's not COVID. And so I think it's related to the prevalence of COVID in your community. That makes a difference. So if you're in Nunavut where they haven't had cases, your runny nose is almost guaranteed not COVID. There's been no cases. If you're in Ottawa and you have a runny nose, the chances that it's COVID are higher. And I will be asking for a scientific review, of the evidence for distinguishing between COVID and, determining that it won't be COVID if it's just a runny nose, because we have a lot of case stories where someone just had fatigue, or they just had a sore throat, or it was a mild headache and it was COVID. So I'm just not sure how you can take those off the list where there's COVID in the community. But I will be looking to our science partners to provide some input.
yeah, and certainly I'm not a doctor either, but it's being done somewhere else here in Canada, and I wonder if it's going to be relevant to us. And so it's good to have your opinion. But just as you mentioned, there's usually a combination of things. And when people come in, if you're going into the hospital, the first thing that happens is you're triaged. You're triaged in terms of the list of things that you have, or the serious level of your concerns. Is that something that's considered in terms of when people go in these lines, so that you can get those people who've like had multiple factors, like they've been somewhere near people and they have the symptoms, etc. Is that considered to make sure that those people absolutely get tested quickly, over and above people that and I know, and I get that asymptomatic people can show up as well, but if there's more than one box ticked, perhaps. I guess that's a Dr. Etch's question more.
Yeah, it comes to the question of prioritizing, and we don't do that based on numbers of symptoms, because we know the symptoms can be mild. But the overall concept of prioritizing based on level of risk is an important one. And again, as we discussed earlier, trying to build that into the operations as much as possible. It's important.
Yeah, certainly you're telling people go there if you have the following. So, but they may go just for, and it may not be in the same level of concern. But anyway,
yeah. If I can just
yeah.
If I can just comment on that, Councillor Kavanaugh, from the teams that have reported back, and this is why I think there's some, it's not always clear cut. So if I went and I was asymptomatic, I would absolutely be talked to in a line to be screened out to say, look, you know what, you don't need to be here. But if you take a 6-year-old that is in grade whatever 3 that's got a runny nose, and their parents work at a place that requires a mandatory test to come back to work, you can't just test the kid when the parent is pushing that they want to be tested. And so part of this is that line management, where most kids that are coming now actually have a parent with them. And because of what's required from either the education system or their work in terms of their employer, they require the test as well, even though they may be completely asymptomatic. So part of this is how do you triage those lines? And when they're single adults, I'm going to say generally straightforward. But when you put kids into the mix, and then you put that employment rule over top of it, that's where these rules coming out of the province that Vera is speaking to are so critical to make sure we're either communicating or getting a handle on. Because if you talk to the people that are in the assessment centers, they'll tell you that's one of the biggest challenges. And so there's not a lot of people without having a significant embroiled debate in the lineup. And so you tend to just have to try and take as many as you can, and then the rest don't come. So when we do go to an automatic scheduling, I think what the team's thought is that we'll be able to book them all in. And ideally is if we can create the mobile driving that also has, the drive-through ones that also take kids and adults, then we can just create more flexibility of getting this all through.
Okay, thank you. You're talking about those sites where people come in cars, and one of the concerns I have is that there's a lot of people in my area that don't have cars, and they're in the vulnerable category. And I really appreciate the partnership with community health centers, because they get what their clientele is like. There's, you know, language issues, there's all kinds of things. And I want to know what efforts are going to be to reach out to that community, communities across, and I certainly have them in my area, where they can't go to a drive-through one. And they need a little more help in terms of getting there. They'd be ideal for pop-ups, I would say. But what is the effort being made to reach out to those vulnerable communities who we know have a higher incidence, because a lot of them work in essential workers, or have essential workers in the family?
Vera, did you want to comment on the discussions with the CHCs?
I'm sorry, I think I underlined before that's one avenue, but I know that CCRC is also looking at sort of central locations where people could walk to sites as well. So it's a priority for the system. We do know we want to tackle where there's inequity, and make sure that everyone has access who needs it.
Okay. Yeah, it'd be very much appreciated. Anywhere that's public transit and walkability is really important. The idea of an app, it was raised earlier, and many people are talking about that for lineups, to be able to be buzzed. I mean, I get one when I go to pick up medication at a pharmacy. Is that possible so people know to come and they're not standing in lines forever?
Yeah, I can't remember which councillor was that raised the same question. That is very much the plan for Brewer, the assessment centers at Queensway and Mulfort, and then any others where the city's able to identify a location where we can open east and west. We want to move to that automated booking. And so, you know, if you know your appointment's going to be at 10 o'clock, most people will show up a half hour early. Maybe it's 5 to 10, maybe it's quarter after 10, but it puts you in the range. And so that's in essence what's happening at the Coventry site, where they can book appointment, pull up in their car. And if you happen to miss it and you show up anyways, and they're going to put you through. But it condenses the line and allows for far better traffic management, not just cars, but people coming through these lines.
Okay. Thank you very much for your responses.
Thank you. Member Lakin, please.
Thanks, Chair. Cameron, thanks so much for being here this evening. Kudos to your patience. You've been at this for almost 2 hours, and it's just a little part of your day. So thanks. And also thanks for not suggesting that all regulated health professionals might be recruited to swab. As a psychologist, I would not think I'd be any good at it, and I'd probably spend more time asking the person how they feel about it, whether I got the right spot. So thanks. I just want to ask very briefly your sense as an outsider looking at this from a macro level, your thoughts about something that informs the public health side of things and the behavioral influences that will impact the spread of the infection. You've talked about Crick's reaction, and that's most interesting. But as we look at the ebb and flow of the infection in our region, we've all heard Vera's team do such an incredible job messaging the things that we know work. Do you have a sense that as a region, we're behaviorally less compliant or not so great at following the guidance that we're receiving? When I hear the guidance from the Premier and Vera, I'm just wondering if the ebb and flow has a bigger behavioral piece here in town than we're giving it credit for. So just an observation, if you could.
So much like your comment that you wouldn't be necessarily qualified to do the swabs, I'm not sure I'm actually qualified to give a general perspective, but I'll give a personal perspective. I think as a region, from a healthcare response, I think we've done a tremendous job, and we've got problems in many areas. And I think the collaboration of rallying around and the importance of testing and things we've talked about, I don't have any concerns on people's angst around this and really trying to get something done to improve it. I think all of the things I've heard Vera commenting on in terms that are probably most important, masking, 2-meter social distancing, no large groups. I think if you think about a population, when I think about the region, I think from Barry's Bay to Hawkesbury down to Cornwall of, let's say, 1.5 million. I think it has done, we've done a remarkably good job of getting that sensitized. I think there's pockets of areas. So as a general community, I think there is pretty good awareness. Can it be better? Sure. I mean, we shouldn't have, if people adhere to all of that, I think that's probably the main thing, just listening to all the public health officers, that is absolutely critical to manage this disease. When you get into institutions, like I've got 1,000 beds, we do 50,000 surgeries. I got 3 COVID positive patients, no staff infected. If you follow all the protocols and the discipline around it, we can absolutely, as a community, manage this disease very effectively. Same with Hamilton, same with Toronto. It's just not just Ottawa. So I think there's always room to improve. And I think when we talk about the spread in the community and getting it under control, the adherence to those practices and continue to reinforce that is critical. Because once you get 1, if people don't follow the practices, you get 2. Like if we didn't follow the practices in the hospital, we'd probably have 500 patients with COVID. The same principle can somewhat apply from a community setting. And you know what, this is just listening to Vera for literally 6 months. It's slowly gone through all of our heads, but she's right. I mean, part of this is why public health is so critical across the province on getting this messaging out, because it's what keeps the community from the spread. And the reality is the large portion will never be admitted to the hospital unless they need ventilation or have respiratory illness. But it doesn't mean that it doesn't spread quickly in the community. So I don't know whether I've listened to you well or not, Vera, but maybe you want to add to that further.
Thank you for that. Vera and I have spoken about this around the table and otherwise, and certainly the messaging has been first class and entirely appropriate. As I watch the ebb and flow of this particular beginning of the second wave, whether as a community, we need to start thinking about some additional kinds of messaging, and that's not for this conversation, but you know, as you see your colleagues in other communities respond, whether we're as a population any more or less compliant. And I think the message is no, we're like everybody else, and we're doing great. So thank you for that, and thanks again for a terrific presentation and taking the time to being with us tonight. Thanks, Chair.
Thank you. Member Menard, please.
Very much, Chair, and thank you for your presentation, Dr. Love. It's very, very helpful. And the list that you read out earlier regarding the communication pieces that you had mentioned, I just wanted to say yes, that would be very, very helpful. It would be extremely helpful to be able to get that out to our residents. So just encourage you to, as that's ready, I'll send it out certainly to my list if that does become available. Thanks for that. On the Brewer Arena, I've been working closely with John Trickett, as well as city staff around some of the lineups there. The card system has been working fairly well in the meantime as a sort of a quasi booking system. And I'm glad to hear that online bookings are coming very soon there. My understanding is there will still be some service in a walk-up, first come, first serve capacity there. Is that accurate?
Yeah, so I'd have to your point, Councilor Menard, I'd have to check with John, but I know what we do is a fast pass system. So if you can't get in the day that you arrive at, and you have to be pushed tomorrow, it's like the Disney lineup. They give you a fast pass to get in the next day so you don't wait again. So I know they put some of those processes in place. They were definitely doing it at Brewer, but I'd have to check in the other centers. I'm not sure of the exact detail, but I think that's what you're referring to, is almost like a fast pass system.
Well,
Yeah.
that's helpful. Yeah, they have been giving cards the last 2 days. Those have been effective. But I guess the question is more, when it moves to an online booking system for Brewer, do you know if there will still be a walk-up capacity, drive-up capacity that similar day? I heard a hybrid model may be coming. Do you know?
I don't know. I'd have to ask the whole crew, and I'm happy to take that away and ask them. I mean, I think when you move to automation, what you want to do is get everyone to use it. Having said that, it's kind of like if you arrive at the emergency department, we're not going to turn you away, but you also don't want 1,000 people showing up when you got an automated booking system. So the messaging we will be putting out is that it's automated, and much like Coventry. But if someone pulled up in their car today and they weren't sure, not unless there was a very long lineup, but there shouldn't be, then they'd probably push them through. But it wouldn't be something we'd message. We want everybody to use the pre-booking system.
Okay. Okay. Thank you for that. As you know, we've also written to you within the core 5 councillors around testing capacity there. You know, in the core, about half of the residents do not own a car, whether just by choice or because they can't afford it. And so I'm hoping you can go into a few more details about timing for more capacity for this type of service. I've heard Sandy Hill Community Health Center, and I've heard Centertown Community Health Center as a potential. Can you give us more information about which one of those may be open, timing, and capacity at that center? That's the big one. Is we're hearing about another drive-through test center within the core, but there's a big need for a walk-up, bike-up, roll-up center that for people that do not have cars.
So you may have further updated information, but I know like there was a discussion over the last week with the community health centers. I'm going to have to get you that information, Councillor Menard. They were talking about how they open and ramp up and what type of capacity they can get. But the whole idea of using the community health centers is to get to that access for those that actually don't have cars and for those populations in those communities. So it's very much part of the plan, but I don't have the detail in terms of, we'll have to get back to you in terms of timing of them. Part of that is for them to ramp up, is to get the staffing, the PPE, all that other stuff in place. And so that's part of the preparatory work. But they are, I think you're right on, don't quote me on this, I think you are right on Sandy Hill being the first one. I just don't know the timing. But the other ones are moving in that direction as well. And then the only other thing that I think is really critical as a community, and this is being talked about provincially, is family docs and primary care. And how do we engage the primary care system in terms of doing this as well? So you can see there's phases of evolution here. While we've got some of the centers that are the big assessment centers, now we're down to how do you get more mobile testing for those populations out in Kinburn, et cetera? And what are you doing for East and West, and then the downtown cores that can't travel? So the testing group that, as I said, has that multidisciplinary group, that incident command with the city and public health is being restructured. It's supposed to, they're basically meeting again tomorrow, so we can start to get some of that clarification. Particularly, I mean, it's one thing to know it's coming. It's another thing to know the time of when it's coming and how much volume. And those are the pieces we have to fill out and put on the public health website and let everybody have access to it and use it as a communication vehicle.
Okay, thank you for that. And yeah, if anything else becomes available in the near term, is it just helpful for us to communicate even a timeline for the future? Because if we tell residents it's ready in a couple of weeks, at least that relieves some of the pressure that has been coming in around that. Dr. Riches, if you have more later in the meeting, love to hear from you. On the my last point will be around something you mentioned in your presentation. You mentioned Greystone Village retirement, and I think it was around long-term care beds. Right now, the Greystone Village Retirement Center was going to be taking residents in. They have said no to that because of the situation that's presented itself. And so are you saying that instead of that, we'll be using some of that capacity for long-term care for the foreseeable future, or can you provide a bit more details about that? That's in my ward along Main Street.
Yeah, so the Greystone facility will be much like a transitional facility. So for patients predominantly out of the TOH sites, Civic and the General, if you look at the Civic, General, Queensway, and Mofor, those are the 4 predominant hospitals that would have a huge portion of patients that are done their acute phase and are waiting for placement to, whether it's long-term care, assisted living, retirement homes, whatever they be. The Greystone home will basically be an extension of those that allows a transitional capacity. So if we can't get them in long-term care for 30 days, some will go there. If they can't get to assisted living, if they can't get into a retirement home, then it gives us capacity to transition out so that we actually can get people in the front door through emerge. So it gives us that that breathing room. It's much like, and I don't know whose ward it's in, it's much like the hotel that was opened in the West End with Queensway. That hotel, very much a similar concept, is a transitional space so people can be cared for safely, but to allow the hospital to have capacity to move. And that also includes time to set up for complex patients that require complex home care support. It can often take a week or two to organize their care. So it gives us a transitional setting to safely manage them.
Okay, that's good to hear. And what is the timing on that? Is there a timeline for when that would start?
October. So it'll be phased in. It's about 100, I think it's about 124 beds, somewhere in that range, between 120, 130. And we'll phase it floor by floor. So it's not like you're going to put 100 patients in the building on day one. You kind of do about 4 or 5 a day and you transition it over a month. So it should start sometime in October, and we want it open by November, so we have that capacity, particularly before we start to see a significant surge in hospitals as we head towards December.
Okay, thank you very much, Dr. And I'm getting distracted by a very sweet baby, so
I can see that.
I better go before I start cooing with the baby or something. Okay, thanks very much.
Thank you, Member Menard. Member Pinnell, please.
Thank you. Thanks, Mr. Love, for being with us this evening and for such a long time. Now, your presentation answered some of my questions, and also, I guess, the questions of my colleague members answered the others for the moment, so that's all I have. Thanks.
Thank you. And on the first go-round, the last is Member Tilley.
Well, Cameron, first of all, thank you for sticking with us tonight. And secondly, just congratulations and thanks to you and the team at TOH, because, you know, it's not too long ago, we all remember a few months ago when this pandemic first hit, and the extraordinary effort of your frontline staff dealing with the influx that they were suddenly hit with, and the efforts they put up in the face of this overwhelming numbers that were coming in. So we certainly still very graphically remember, like most countries, we saw the shortages of PPE, of masks. Dr. Edges talked earlier about trying to teach people to learn proper behaviors, and that was a whole education process. So, you know, we talk about how we're a little better set up to deal with this current second wave and if it rises and escalates, we still would be. Do you foresee that you'd be able to split the two in dealing frontline, yet then with whatever may come your way now versus then, and yet still carry on with those elective and other surgeries that now that we're better positioned, you'd be able to split that and not have to deal with that, abandoning those procedures?
Yeah, great question, Peter. The short answer is yes. I think, and this isn't just unique to Ottawa, it's all across the province. When you take patients that require surgery within 6 months and you push them out 6 months, there's a classification system on how surgeons classify patients in terms of order of priority. But what we're seeing is because we've pushed them out so significantly, their disease has progressed to the point now where they're either in significant pain and they become an urgent case. And so even when you take cataracts, which is a fairly simple procedure, the number of people that require cataract surgery for fear of blindness now is climbing. So as we ramp this back up, to your point, we've sort of laid this out to make sure that we will keep intact surgical services, to make sure the access for those families, particularly when it's cancer related, that no matter what happens in wave 2, we have to get that activity through. And so the short answer is yes on that particular service. And those are pretty specialized services when you talk about the surgeons and the nurses and anesthesiologists. So those ones we've made sure we've kept intact and that we're able to run those complicated services. Same things with things like trauma and our bone marrow transplant programs, all of our cancer patients, NICU, all the NICU staff. Those are teams that are, I'm 100% confident saying that those services will continue to run regardless of what happens to wave 2.
That's great to hear. Thank you.
Thank you very much. That's the complete list, but because Member Banham is such a cute baby with her, she has one more question she'd like to ask. So I'm going to turn it back over to Member Banham.
Hi, sorry. It's the hazard of going first. You think of new questions while everybody else is asking.
I was wondering, so with the move to online booking, I have concerns about the older adult or elderly population and those without internet. Member Menard started to talk about this, but I'm just wondering if, knowing that those populations are already vulnerable and knowing that they're already isolated, just maybe if it hasn't been thought of yet, if that is going to be brought back to the planning committee, just to make sure that you know, we're getting to the people who need to be able to be accessed.
That's a great comment. I don't actually, I will raise it with the group. I will tell you just anecdotally, most of the elderly population, this is strictly related to a hospital comment, but I think it still applies. Most of the elderly population, it's incredible how many of them are adverse in terms of using electronic mediums now. And for those that aren't, typically a family member is going to do it with them or bring them to begin with. So I think we've got a fair chunk of that covered off. It's the same as when we run all of our outpatient clinics, the same type of thing. But it's a fair comment. I'll take that back, because if it does become an issue, then we need a sort of a secondary system that's more paper or call based. But what we find, like, to give you an example right now, we do about 1 million outpatient visits a year for clinics. Pre-COVID, we had about 20% that were virtual care, which means people are on the other end on a computer. Today, we're at about 87%. And a large portion of our outpatient clinics, probably the average age would be 65 plus. So, you know, there is a very strong presence of people capability to use electronic technology now, but it is a fair comment that for those that can't, then we do need to think about how we put them through. Yeah, great comment.
And because I let Member Banham have one more question, is there anybody else that has a follow-up question for Cameron before we let him go? Going once, going twice, gone. Okay. Thank you, Cameron, for coming and presenting to us and taking our questions. I see a number of really positive takeaways from this. The development of sort of a one-stop shop website, which you indicated is, you know, just weeks away. Discussion of, you know, finding different locations, different sites, also very, very welcome. So much appreciated. You know, perhaps you can come back and visit us another day. You know, because unfortunately, I think we're going to be in this scenario for some time still, and we may well, you know, welcome you back and have further questions and comments for you. So again, thank you, and we'll hear more back, I'm sure, flowing through Dr. Etches and her team as to where CRIC is, or maybe CRIC isn't going to be CRIC anymore. Maybe it's going to have another better acronym than CRIC, but also, you know, more cohesive, better communications, and more, I think the term used was flexible to addressing COVID, because we've learned anything from COVID, it's extremely flexible. And we think we've got it, and it takes an end run around us and does something different. So we have to be equally adaptable. So thank you for that.
Great. It's nice talking to you all this evening.
Thank you.
You as well.
Bye all.
We're going to move to, so do we receive this report?
Received.
Received.
Thank you very much. Any dissents? No, excellent. We'll move to the next item, which is my report, verbal report. So I'd like to begin my verbal update this evening by congratulating Dr. Sarah Fennell, one of Ottawa Public Health's Associate Medical Officers of Health, on a recent appointment to the College of Family Physicians of Canada Board of Directors. For those who may not be familiar, the College of Family Physicians of Canada is the professional organization that represents more than 40,000 members across the country. It establishes standards for and accredits postgraduate family medicine training in Canada's 17 medical schools. It also reviews and certifies continuing professional development programs, and materials enable family physicians to meet certification and licensing requirements. Congratulations, Sarah, on this prestigious appointment. On August 13, 2020, I had the pleasure of participating in a virtual event organized and hosted by Ottawa Public Health to launch the Mental Health of Ottawa's Black Community Research Study. We are fortunate to have CBC Ottawa's Adrian Harewood serve as Master of Ceremonies for the event. OPH's Hoden Aden and Januda Oraka presented the study's findings, and participating as panelists, we had Police Chief Peter Slowey, Dr. Etches, Councillor Ralston King, who's the City Council's liaison on anti-racism and ethno-cultural relations, Camille Williams-Taylor, Director of Education with the Ottawa Carleton District School Board, and Sheila James, a Diversity and Inclusion Specialist with the City of Ottawa. Board members were invited to watch the events live stream on Ottawa Public Health's YouTube channel. I hope many of you were able to do so. The mental health of Ottawa's Black Community Research Study was developed to contribute to and improve data representing the Black community. The research study was conducted due to the lack of current data on perceptions, experiences, and needs of Ottawa's African, Caribbean, and Black community in related to mental health and access to quality mental health services. This research explores the experiences of Ottawa's ACB community in relation to mental health and mental health care and the mental health care system. The study examined research participants' views and perceptions of mental health, protective and risk factors, interactions with mental health services in Ottawa, and strategies to improve services for Ottawa's ACB community. OPH, in collaboration with the over 14 community partner agencies, delivered this project over an 18-month period, and 130 research participants from Ottawa's ACB community participated in the study. Multi-level and intersecting factors protect or expose people within the ACB community to risk in terms of their mental health status. Participants identified a wide array of individual, family, community, and societal factors that influence mental health. This pre-COVID-19 study also revealed several optimistic findings in terms of the research respondents' self-rated mental health, sense of community belonging, and stress levels, which were better than the city average. Findings also revealed a number of significant obstacles encountered by participants, including stigma rooted in cultural sensitivities, racism, limited employment opportunities, and financial insecurity, lack of access to culturally safe care and/or care providers with similar cultural and racial identity, among others. The findings and recommendations from the study include strategies to improve services and experience for ACB populations and may be useful to policymakers and service providers across the city. These recommendations will lead to improved collaboration in the management and delivery of mental health programs and services. As part of its commitment to advancing this work, OPH will keep advocating for intersectoral collaboration that will address issues related to social determinants of health targeted at improving access to mental health services and improving mental health outcomes. It will also work with the ACB community and the city's anti-racism secretariat to explore implementation of public health specific recommendations. I look forward to hearing more about this work as it moves forward. On August 31st, we recognized International Overdose Awareness Day. This annual event to raise awareness of overdose and reduce stigma of drug-related harms and death. It is also time to acknowledge the grief felt by families and friends by remembering those who have been affected by drug use. Overdose is a continuing risk for people who use drugs in Ottawa, particularly with the emergence of stronger opioids across the country, like illicit fentanyl. This year has been especially challenging for many in our community, and it was important for our community to still gather together at a distance to recognize this important event. Even through the COVID-19 response, OPH has not wavered in the recognition and support for individuals who live with problematic substance abuse or substance use disorder. It is recognized that COVID-19 has exacerbated many of the issues experienced by members of our community who use drugs and alcohol. The harm reduction services provided by OPH are incredibly valued in the community, and it's important to recognize the work of OPH staff to identify innovative solutions to provide important services during the pandemic. Unfortunately, problematic substance abuse, in particular the opioid crisis, continues to take lives across Canada. Report barriers to accessing the services that they need. And we know stigma is one of the biggest barriers. This stigma simply needs to end. It is one of the largest barriers to accessing help, and OPH and our partners are dedicated to providing access to equal and judgment-free help. Safer Supply Ottawa partners are continuing to work to expand access to programming in the community to decrease the risk of accidental overdose and improve health. These services provide access to prescribed pharmaceutical opioids and further connect people who use drugs to integrate wraparound health, social, and treatment services. Safer Supply Ottawa is supported by Health Canada's Substance Use and Addictions Program. OPH is proud of the collaborative work with our incredible partners, such as the Community Addictions Peer Support Association, Drug Users Advocacy League, the Canadian Centre on Substance Abuse and Addiction, the Canadian Public Health Association, and the Royal Ottawa. Ottawa Public Health strives to learn more and do more to advocate for the needs of people with lived or living experience of substance use disorders, reduce stigma to help remove barriers to accessing services, and promote harm reduction principles. OPH uses this knowledge to work towards a society where no one is forgotten or denied the care they need. As you all know, on July the 15th, Council adopted a temporary mandatory mask bylaw based on recommendations from our Medical Officer of Health and the city's General Manager of Emergency and Protective Services. The rationale for the bylaw was based on increasing evidence that wearing a mask when in enclosed public spaces is an important measure in reducing COVID-19 transmission. The scientific community and public health organizations around the world have concluded that the cumulative weight of evidence support that face masks lessen the rates of transmission of COVID-19 from wearers. However, other community level measures such as physical distancing, hand hygiene, and staying home when sick should continue to be employed to decrease transmission of COVID-19. Given its nature, the bylaw was to be revisited at the next council meeting scheduled for August the 26th. In revisiting the temporary mandatory mask bylaw, City Council again approved recommendations from our professional staff and extended the bylaw until October 31st of this year. This included amendments that effectively expanded the bylaw's scope so that it now applies to indoor common areas of apartment and condominium buildings and vehicles for hire. It also allows for the establishment of mandatory mask zones should the need arise. Ottawa is continuing to see a fluctuating rate of people infected with COVID-19 in our community. In recent weeks, we've experienced an increase in the reported number of people infected with COVID-19, which has served as a stark reminder of the potential for this virus to spread if it is given the opportunity to do so. With the virus present in our community and the vast majority of residents being susceptible to infection, it is critical to exercise precautions and continue to be COVID-wise to prevent transmission that could overwhelm our healthcare system and lead to deaths. We also know that keeping transmission under control is key to Ottawa's economic recovery and to a safer return to school for children in our community. These are the factors on which Council based its August 26th decision to extend and expand the temporary mandatory mask bylaw. Given the October 31st sunset date, Council will be revisiting the bylaw again next month, looking to our professional staff for advice and recommendations. Notwithstanding the requirement for wearing a mask in indoor public spaces, other public health measures continue to be of utmost importance, such as physical distancing, good hand hygiene, and staying home when sick. September 10th was World Suicide Prevention Day. To commemorate this day, Ottawa Public Health, in partnership with Suicide Prevention Ottawa, hosted a virtual event to raise awareness, hope, and resilience, and to increase help seeking. This year, the theme that Ottawa Public Health and Suicide Prevention Ottawa selected for World Suicide Prevention Day was One Good Thing. This was done to acknowledge the importance of emphasizing stories of hope and resilience during these challenging times. Suicide is complex, but suicide prevention can start with one good thing. Individual acts can have a great impact. On World Suicide Prevention Day, we encourage people to come together to emphasize stories of resilience and survival. The online event featured 2 community members who talked about their lived and living experiences via virtual chat and discussed the services and supports that helped them along the way. The event has had 1,000 views to date and can be found on Suicide Prevention Ottawa's Facebook page. Suicide is and will continue to be an important public health priority. As co-chair of Suicide Prevention Ottawa, a network of 40 plus organizations working to prevent suicide, OPH will continue to raise awareness, develop resources and programming, and increase suicide prevention training across Ottawa. Lastly, on September 25th, the Community Addictions Peer Support Association, CAPSA, will be hosting Recovery Day virtually on Facebook Live from 3 to 8 p.m. Recovery Day at Ottawa is an annual community event organized by CAPSA Canada in the month of September, and in the past has been held at City Hall. If you've not been before, I recommend that you attend, even virtually. It is such a life-affirming, positive day, and I recommend it to everybody. The purpose is to help reduce the stigma surrounding substance use disorders and addiction and raise awareness about recovery in our community. The goals of the event are to celebrate the many pathways to increased wellness in our community, foster hope for those who still suffer, reduce barriers of stigma and discrimination directed towards those affected by substance use disorder, engage the broader community in support of stigma reduction and increased wellness, and build a platform for dialogue on increased resources for new and existing services in our community. Our children and youth is dependent on keeping, sorry, I jumped ahead there on you. We also need to think ahead about what could happen as we move into fall and the flu season. I recognize the past 6 months have been tough, and there's some COVID fatigue settling in. However, given the recent increase in the number of people testing positive for COVID-19 in Ottawa and the potential consequences of letting our guards down, I urge everyone to get back to basics, thinking about and in implementing public health measures in their daily lives. We just spent over 2 hours talking about the challenges of testing. Well, one of the ways to avoid testing is not to get symptoms in the first place. And the best way not to get symptoms in the first place is to be COVID wise. And that's simple, basic things. Wear a mask, isolate yourself if you're sick, stay 2 meters away from people outside your household, exercise proper hand hygiene. We really are all in this together. We have a collective responsibility to do everything we can to protect ourselves, our loved ones, and our community. That concludes my verbal update. It was a lengthy one, but it was important to highlight, I think, the things that public health is doing over and above COVID, the challenges that they're still taking on each and every day. And I want to thank all the public health staff that I know are stretched just about as far as anyone can possibly be and still delivering the services that are so necessary to the health and well-being of our community. So thank you, Dr. Etches and your team. I'm happy now to take any questions that anyone might have. And given the lateness of the hour, I'm happy there are no questions. So I'm now going to pass it over to Dr. Etches, her to present her verbal report.
All right, hello everyone. It's almost time to say good evening, I think. Bonsoir. I want to talk about tonight a provincial announcement about the Ontario Health Team's position statement on stigma and COVID-19.
You need to receive your verbal.
Oh,
Vera, sorry to interrupt,
yeah,
but
no problem.
Deanne is just reminding me that we need to receive the verbal, my verbal report. So received?
Received.
Thank you very much. No dissents? Thank you. Sorry about that. Back to you, Dr. Etches.
Not at all. So the stigma in COVID-19, we will talk about this fall's influenza campaign and then our ongoing work around COVID-19. Want to address the schools reopening, among other things. But first, today is the start of Environmental Public Health Week. So we want to recognize our public health inspectors and others who work in environmental health. The theme for this year's Environmental Health Week is that public health is a collective effort. And I think that fits with the comments we've heard earlier this evening. But, in addition to their work on health hazards, rabies prevention, answering calls on our intake line, inspections, helping with reopening after COVID in restaurants, personal services settings, recreational water, the small drinking water system. People wanted those pools open. The public health inspectors are in high demand, and they've been crucial to the pandemic response by mitigating risk and managing outbreaks. Also, especially important work in long-term care homes and congregate settings. Childcare facilities, there's so many things. We're very thankful for their work. I just want to recognize how fortunate we are for environmental public health specialists. The Ontario Health Team announcement is that following a bit of a pause with the pandemic in the spring, on July 23rd, the Ministry of Health announced 5 new OHTs, Ontario Health Teams in the province, including the Ottawa East OHT. So nous sommes un fier partenaire de l'équipe Santé Ontario de l'Est d'Ottawa, and that brings the total number of approved OHTs in Ontario to 29. In July, the ministry also announced that they would be giving implementation funding to support all approved OHTs. Access to this fund requires that there's an established collaborative decision-making agreement. And so both the Ottawa Health Team and the Ottawa East OHT are in the process of finalizing and signing off on these agreements by the end of September. So as delegated, the chair and I will be looking at those agreements. They formalize really the current way of working together. They don't duplicate or replace any partner's governance or operational decision making. And so I don't have any concerns with what's been brought forward to date. The work of Kids Come First has also continued. And so, throughout the pandemic, it's being used to respond to the needs of children, youth, their families, and providers. The Three Rivers OHT, led out of West Ottawa, remains in development, and that is in conversation with the ministry about next steps. À bien des égards, COVID-19 a accéléré les possibilités de travailler en collaboration dans l'ensemble du système de santé. And I think having Cameron Love speak to us earlier shows us how much collaboration is happening in new ways because of the pandemic. I will speak next about this position statement that Ottawa Public Health put out about stigma and COVID-19. We wanted to raise awareness about stigma that has occurred for people who have tested positive for the virus, or people who might be thought to be carriers of the virus based on their appearance, and people who are thought to be from areas where COVID-19 originated. As many of us are aware, stigma is a negative stereotype or a negative association with a group of people. Spoke about it earlier, the chair did, related to substance use. And our data does show areas where a high proportion of racialized communities with high material deprivation do have higher rates of COVID-19 compared to lower neighborhoods with lower proportions of racialized communities or deprivation. And this could lead to stigmatizing, assumptions and discrimination. If people may feel this, they may not even access care or go for testing. And so we really want to make sure that we have a system that minimizes these negative outcomes. We want people to feel supported, not hindered from sharing information about their contacts, not feeling isolated. Even, we must ensure people avoid facing violence. And so through the adoption of this position statement, Ottawa Public Health is hoping to raise awareness and build compassion about how we use language and about the stigma that people are facing. So we talk about people first language that respects and empowers people when discussing COVID-19. And this is when we talk to clients, partners, stakeholders in the media and on social media. And I know my own language has needed to be adjusted from our typical public health approach where we talk about cases. We are now talking about people who are testing positive for the virus. It's not, it's a person, all right? That just reminds us when we put that person in there. Nous sommes en train de revoir les documents internes et externes, de sensibiliser le personnel et d'informer nos réseaux et partenaires sur l'importance d'éviter les termes stigmatisants. So we are sharing this, this position statement far and wide. When it comes to the fall flu vaccine campaign, the chair spoke about it at council actually last week a bit, noting that so far we've managed to keep case numbers low enough to avoid a rise in hospitalizations, which would burden our healthcare system. But the upcoming flu season will present another challenge potentially on that front. So I want to build on that and provide the board with a bit more information about our plans for this fall's immunization campaign. So normally about 40% of the population is immunized, and we are going to set a goal for a community of 70% of us to be immunized. So that's ambitious. That's, you know, heading towards double, but it's at a level where, you know, it would really assist with herd immunity if we had 70% of our population immunized against influenza with an effective match in the vaccines. La vaccination de la population contre la grippe est essentielle chaque année, mais cette année, elle est de la plus haute importance. So if you don't normally get the flu shot, we're encouraging you to get one this year. And there is a potential for a rise in the numbers of people with COVID and the flu, which could make people very, very ill, certainly overwhelm our emergency departments. We can blunt that impact by limiting transmission of influenza. So Ottawa Public Health is the distributor of influenza vaccine according to the provincial universal influenza immunization program. The province determines which vaccines will be available for which populations, in what quantities, and when. And then Ottawa Public Health quickly turns around to supply the hospitals, the long-term care homes, and community immunization providers. Pharmacies do access vaccine directly from the province. So typically, Ottawa Public Health immunizes, directly 11,000 people with influenza vaccine. But the 2020 plan is going to aim for double that. And this will be starting in October. Ottawa Public Health will be offering 3 different options for residents to receive their flu vaccine. First, we will have the universal clinics that people are familiar with, where Ottawa Public Health will provide flu clinics in 6 fixed locations. You'll be very happy to hear, to avoid crowding and control the flow of clients in and out of locations, offering them by appointment. Physicians and primary care providers will be providing flu vaccine to their patients. And typically, Ottawa Public Health distributes 217,000 doses of influenza to physicians each year. And so, in addition, this year, Ottawa Public Health is going to be offering joint clinics, where there'll be an opportunity for primary care providers to immunize their patients in a Ottawa Public Health community physician clinic. This collaboration will help address some of the challenges that community primary care providers are identifying when it comes to limitations with their offices' ability to handle influenza immunization in this time of COVID, such as adequate space or post-vaccine monitoring. And the last third way that Ottawa Public Health will be promoting immunization is through outreach to populations facing greater barriers, including isolated populations. And we do this every year, but this year we are adding capacity, working with partners, including the Canadian Red Cross. So we're going to offer targeted immunization clinics in shelters, group homes, other congregate settings where residents are not able to access the universal clinics. And in addition, beyond this, we'll be engaging hospital partners to make sure that they're immunizing their employees as usual, but also opportunistically immunizing patients when they're admitted, even through the emergency room potentially. So pharmacies will be providing the flu vaccine to Ottawa residents age 5 and up. And in 2019, the pharmacies received approximately 168,000 doses of influenza vaccine. So again, a huge contributor, and we do expect pharmacies are indicating that they are prepared to do their part. This at least this much again this year. So in light of the ongoing pandemic, this year's clinics are going to look different. Not only the scheduling, but also there'll be precautionary measures. So screening staff, volunteers, and clients for illness or exposure to COVID-19. Physical distancing in terms of the clinic layout and the number of clients allowed in the clinic at any given time. Infection prevention and control measures, including the need for personal protective equipment. Increased environmental cleaning, and making sure again we pay attention to the client flow to avoid crowding, and we will be enhancing our communications related to these processes. So lots of talk. I'm going to give you something visual to look at next, as I'm sort of going to just shift from my verbal into the COVID update. If you can bear with me, that way we cover off the last item on the agenda, and you can ask your questions all at once. Does that make sense to folks?
I think that makes eminent sense.
Okay, so let's just go through this. In terms of the COVID update, so on the first slide, next, please, Diane. It's kind of a summary, right? Like, where are we at now? What's the epidemiology? And we have previously been public and vocal saying we're orange. Red is when our systems are overwhelmed and we can't cope, and there's a rapid increase. I can tell you some of our indicators are red right now, but we're mostly orange. Yellow would be when the outbreaks are rare, when we don't see COVID entering into more vulnerable settings, for example. And so we're in the middle. But we are concerned about the number of people testing positive for COVID-19. It's increased in July, came down a bit, it's gone up again through August into September. And it really does look like we're approaching levels seen in the first wave mid-April when it comes to infections identified in the community. But compared to the first wave, there are more infections in people under 40. And so that's not leading to the hospitalizations growing at this point. It does make a difference for entry of the virus into schools to have this higher level in the community. And so I am interested in getting the levels lower. Like it's not going to continue to be that workable if we can't change the increase to flatten that curve again. We are struggling a bit, so we're just not quite meeting some of the targets for follow-up around connecting with people who test positive and their contacts, although we're not far off, and I'll speak more about what we're doing to increase our capacity. The testing volumes have increased. They have, and another indicator related to testing is what percentage are testing positive. And that's worrisome to us because that has grown, and that indicates that there is more COVID in the community. With the increased testing, the turnaround times to get results is also increasing. It's taking longer. So that's a summary. And next, I wanted to show, I want to speak a bit more about long-term care because of the concern, and member Councillor Kavanagh spoke to this. We have seen more deaths just recently, and it is because of outbreaks in long-term care homes, which have gone up in number. For the most part, the majority they're not seeing transmission like they did previously. People have learned how to stop COVID transmission. It usually starts with testing a staff member who has symptoms or is picked up on surveillance testing. And often now what we're seeing is it doesn't go much further. They've been contained to the staff. However, once we start to see spread in the residents, it can spread more rapidly, and so we're concerned. In particular, there are 2 instances, unfortunately, where more supports have been needed in the homes. So really taken unprecedented action. Haven't done this before, but we've learned from the first wave. It's typically the Ministry of Long-Term Care that oversees management in homes and intervenes in how homes are managed, but that process can take some time. And so an expedient way to act is to use the Health Protection Promotion Act, where the medical officer of health is able to order, in this case, the Ottawa Hospital, to assume responsibility for providing care and leadership in the homes. So this was for the West End Villa long-term care home, which was effective September 18th, and also to Extendicare Laurier Manor, effective September 20th. So all partners are open to this. This is something where everyone agrees it makes sense to have more supports in the home. The Ministry of Long-Term Care, Extendicare leadership, the Ottawa Hospital, and Public Health. So it's just a measure that makes it easier for that to happen. And I think the other points on this slide about long-term care, not to take too long, but Cameron had mentioned that Public Health has a role in assessing how homes are doing, and it is our team on the ground that can understand where a home might be getting into trouble. So we do rank them still according to green, yellow, and red, and you can see the things that lead to a home becoming yellow or red first and foremost are often related to staffing shortages. This is a theme tonight, I think. If people don't have enough staff in the home, then you start to see challenges with care. You start to see challenges with implementing infection prevention and control practices. And so, these are things that we flag and we escalate, and we are looking to find solutions with partners. So we have been continuing to go out to homes and promote good practices after the first wave, and this is a partnership. Again, you can see the Champlain COVID Response Committee provides some supports, the Ministry of Long-Term Care, and we are for retirement homes in touch with the Ministry of Seniors Affairs and the Retirement Homes Regulatory Authority. So, sorry, we'll move on. Happy to take questions. When I presented at council last, I shared a real world example of contact tracing, and I wanted to do that again because people were curious. They want to know more about where are people getting infected? How does it happen? So the example I shared previously was 10 people in a cottage. One person with symptoms quickly became 40 people who tested positive for COVID within 9 days. Here we have an example where it was outside, actually. It was a park party of 40 people. And 2 people went on to develop symptoms from that group. You can see on the diagram, one person went on to have some close contacts and people test positive. In another household, it really had a significant impact in terms of 2 workplace outbreaks, one in a childcare setting where there was transmission among staff, and then 2 children who became symptomatic and went to school, 2 different buses, 2 different schools, and there were 105 high-risk contacts then that needed to self-isolate for 14 days and go and get tested. So you can see how, again, group of 40, couple people ill, quickly can lead to 105 people having to stay home and multiple more people testing positive. So this is why, we do appreciate the provincial recommendation to address some of the source of transmission by limiting social gatherings. I'm going to go on to the next slide, Deanne. So school reopenings. With respect to schools, our focus has been supporting school boards to implement the provincial directions and provide support and guidance to make the return to school as safe as possible. Board members would be aware that the province announced funding for 500 school-focused public health nurses, and 45 have been allotted to Ottawa Public Health. We have been able to hire all 45 public health nurses, and I'm really happy to say 40% of them are bilingual, and we have a significant representation from racialized communities. And so this is a good start. They are very busy already. They've been assigned to more than 290 schools. Each nurse has a portfolio of between 4 and 12 schools, and it depends on the number of factors, depending on the burden of COVID in the different communities. The school nurses have been reaching out to build relationships with principals and the school community to support the reopening plans. They've also been building their own knowledge, right? Their capacity and confidence. They're having daily huddles, end of day briefs, practicing case interviews. There's that word again. Practicing interviewing people who've tested positive for COVID. Mentoring is happening by more experienced team leads and leadership. We've had very positive feedback from our 4 school boards as these nurses are fielding questions all the time. And as of yesterday, there have been 28 schools in Ottawa where an individual has tested positive for COVID while they attended the school. So the numbers might be slightly different from what the Ministry of Education website reports of numbers of people in schools testing positive, because we are interested in the ones Ottawa Public Health also ensures that those high-risk contacts are on a do not attend list that informs the school of who should not be in school, who needs to be home to await public health contact. I can tell you the school nurses, I think it's been extremely, I think we are going to add to the team. Like it's a lot of work. What they've had role to do is to help with the identification of contacts in the schools. They help to investigate and determine what is the risk level for people in the circle of contacts in the cohorts. They help make up the lists. They help manage the lists of who's home, who needs to be. They help with the initial contacts and the communications more broadly in the school community. They are helping to make sure the information gets into a system that we're automating. So we're making sure that we can have an automated notification out initially so that it's faster for families to hear from us, either by a phone call, a text, or an email. And this is something that's underway now. And they are also then the nurses helping with the discharge list management, when people can get off the list of do not attend, and making sure that the schools have all the information. So we are planning debriefs because there are things to learn. So far we have been adapting communications based on outstanding questions from parents and schools to provide further clarity on who in your family needs to be tested, as well as who needs to self-isolate. This past weekend, in coordination with local healthcare partners, we also made use of mobile testing clinics. They were on site at Franco West and De La Salle high schools to provide COVID testing to students and staff who had been identified as high-risk contacts but hadn't yet been able to get tested. The staff and students with symptoms of COVID-19 were also eligible for testing at these mobile clinics. And it was Ontario Health that made these mobile projects possible. We want to thank them for that. It did enable us to test about 275 people over the weekend. We think that this is something that we'll be able to continue to rely on, to be able to use the mobile testing for schools where there's a larger number of close contacts that require testing. Now, we've had also the first outbreak identified at Monsignor Paul Baxter Catholic School on the weekend. And so on-site testing will also be offered tomorrow to close contacts identified by Ottawa Public Health, as well as anyone in the schools that has symptoms. So in accordance with provincial guidance, an outbreak is declared in a school once it's determined that 2 individuals have tested positive for COVID-19 with an epidemiological link. And we have confirmed 4 COVID-19 positive individuals at the Monsignor Paul Baxter Catholic School. In this case, a whole school dismissal was instituted because Ottawa Public Health determined there's a concern of possible transmission of the virus in the school, and the potential risk of transmission is not localized to one class. So we're working with the school board to actively contain the situation. And we're working with school principals and reaching out to close contacts directly to provide direction, isolation, instructions about when to be tested. And we're including information, that only those contacted by Ottawa Public Health should seek testing. This outbreak's disclosed on our website, and we're going to continue to use our website to continue to communicate about outbreaks in schools. In this case, the duration of the school closure hasn't been established definitively yet, but parents and guardians, we're saying, should be prepared for a closure of 2 or more weeks. And Ottawa Public Health is going to be working with the school board to make sure that, of course, any necessary infection prevention control precautions are in place. And we have more information on our website about our work with schools. So I'm going to skip over some of the next piece, I think on the next slide, around testing. I think, this is sort of what Ottawa Public Health is responsible for on this slide. We're leading around communications. We're connecting people, whether they're in the healthcare sector or in the city, social services or business sectors, where we play a role in facilitating connections for a coordinated response. Some of these things you can see on our list. I think the idea about the testing strategy and OPH's role is we're mostly there for advice and recommendations. I think that came through earlier in terms of who needs to be tested, what we'd like to see, across the city in terms of, access and points of access and what's needed to meet the needs. So I'm going to move on and just be conscious of time. I want to spend just a moment, though, to say that it is very significant how much of our team has been redeployed and is no longer doing our usual work. I mean, it's really down to only the dental team that's preventing people from going to emergency rooms with emergency work, only our supervised consumption service and sexual health team that's treating people who don't have another point of access when they have symptoms that need assessment. We are only doing complaints for safe food and water inspections at this point, or where we know there's a critical infraction that needed follow-up. We're even limiting some of the follow-up we do on communicable diseases because we need to focus on the follow-up with people who test positive and their contacts, with the outbreaks and with the schools, and doing the communications work related, and answering questions of partners, the liaison work, supporting the economy. So what we are doing to add capacity is multiple different streams of activities. Certainly, appreciating that the City of Ottawa is going to be able to provide some people to help with more administrative tasks or data-related tasks. We have been using the Public Health Ontario central resources for contact tracing, and we've doubled the number of people that they're helping us with, and we've been exploring further direct agreements to be able to have support for people dedicated to Ottawa Public Health for this work. We have been looking at even outside of the city, partner organizations like the police. Ottawa Police have said they could potentially help, but in the end, sometimes we are having to hire. We need new people to help us. And so this is where you see some of the implications in our budget report that you carried, that this does relate to the overspending. It's mostly about bringing on people to help with this work. We have been looking at third-party contractors, but at this point, we haven't entered into any agreements. So there is a note here that we're reorganizing, and I think I want to speak to that as well. I'm just checking to make sure I'm on track with what I wanted to say. The reorganizing is about actually first of all at the senior management level. We are trying to spread out the work. So I can come back to that in a moment. But then underneath a new senior management level, there's implications for everyone. So trying to make sure that all the new people we're bringing in have the right supervisor, and are collectively, have a reasonable workload. So this idea that we need to promote the wellness of our own team to be able to carry the work out is very, very much appreciated. And right now, the teams are stressed. It's certainly, new work, things people haven't done before, and we are trying to support. So I think I am off track, but I'm going to just go to the next slide, and I can probably come back. I wanted to mention something more on that subject in a moment. So the other piece in your package related to the COVID update report was some work by the public health sector. The Council of Medical Officers of Health has created a lessons learned kind of document, sort of an evaluation of the response so far and some thoughts about what could be applied or learned to support the response going forward. So certainly you'll see that, as has already been discussed this evening, there are disproportionate effects in different populations, and we need to adjust our supports to mitigate that. The mental health challenges have been real. The socioeconomic impacts have been devastating in many instances. We know, unfortunately, people have lost their work or even their business, and so we really need to find a way for people to continue economic activity. I've mentioned some of the challenges to the long-term care and some of the benefits again of working closely, public health and city partnerships across multiple sectors and with health units. Moving on, Deanne, please. I have mentioned that we're going to be looking at the budget for 2021. You carried, I believe, the recommendation that we prepare a budget that reflects the level of work that we have to do. We will be putting more specific recommendations forward to address some of the challenges that we've been seeing so far, including, contributing to the review of the long-term care home situation. And we do think that there are some lessons learned for strengthening the public health sector as a whole, and the modernization discussions, which we understand may be started again. So I want to conclude by really recognizing our partners. Je tiens à profiter de cette occasion pour reconnaître nos partenaires. Certainly the boards of education, the principals, the superintendents, the staff, the teachers in the education system have really been incredible. And really there's been a lot of joint work with the focus of staff and student safety. But children, parents, families, they put their faith in us too to go back to school and use new behaviors like being COVID wise. And it really is important. I want to emphasize that this is one of our key goals at the moment, is to keep schools open. We want to prevent COVID in the community so we can keep schools open, and it does take all of us. Of course, the City of Ottawa is continuing to help us with significant human resource as we bring people on, significant human resource support and IT solutions as well. And I just want to sort of pause then to recognize the incident manager for the Ottawa Public Health COVID-19 response. He served in this role from the start of the activation of our response in January until last Friday, and that's Andrew Hendricks. He's been the incident manager, and that role's just ended because of the reorganization of the Ottawa Public Health senior leadership team to spread out the work across senior leaders. But Andrew really was the one who carried this response for this long. And I have a little thank you for him. It's a picture of people with their teams photos and some words of thanks, and so many staff members just noted that he was an outstanding leader. He is an outstanding leader whose approach was calm, that really helped people through some very trying times with a subtle sense of humor, and you can just see without him the team really would not have been able to accomplish all it did. So I just want to thank Andrew really very much, and see some heads nodding. So the idea of moving out of the incident management system is that we have to sustain this response for another year plus, and we need to avoid competition between COVID work and non-COVID work, and work as a whole organization to have that flexibility to continuously adjust our programs. And so this new senior management team does include Dr. Brent Millochny in a new role. We've reinstated the Deputy Medical Officer of Health role. And there is a leadership role for Sherry Beadle as well. I think you would know she's our Chief Public Health Inspector, and she's joining the senior leadership team. She's overseeing health protection, including the outbreaks response, infection prevention and control, as well as others. You would be familiar with food and water safety. And a new area is community operations. So this would be, again, a new senior leader role that's focused on the communities who are facing more barriers to limiting COVID transmission and accessing supports and services. So this new leader will be able to announce very shortly. We're wrapping up interviews, but I do want to recognize, based on some of the comments and questions people had earlier, that this is a priority and it's going to have its own focus from the senior leader level. We do think, again, prevention is the first goal, and we need to have very much a leader who works with communities, understanding communities' needs, working alongside, working with other community partners. And part of this is hearing from counselors about what you're seeing the needs are of the communities as well. So look forward to doing more on that front. So that concludes my verbal update, and I'm happy to take questions. Il me fera plaisir de répondre à vos questions.
Thank you very much, Vera, and I echo your comments on Andrew. Long hours, many days, many months, and always in good humor. I think that's the key to how Andrew operates. So thank you for that. There's been a request from Councillor Menard, Dr. Etches, to be able to share your PowerPoint with the members of the board, so that they can share with their networks and residents as needed. So I'm assuming that's not an issue.
No, that's fine. Yep.
Does anybody, again, keeping power, and we've asked lots of questions to Dr. Etches earlier on. Are there any questions arising from Dr. Etches's presentation? Yes,
thanks just a shout out to Andrew and for all his work, and I just don't know how he did it. It was amazing. Thank you. I don't want to prolong it, but understand that how the reorg is needed, because the pandemic is becoming the new reality, and we can see how it's all changing. Thank you.
Thank you. So yes, Member El-Shantiri.
Dr. Atchis, you mentioned about food inspections and restaurant opening, reopening, and so do we know how much that create extra workload? Because I know some places close down, then they have to reopen, and then they have to get inspected. Do we have a number increase 10%, 20% workload? Do you have any idea?
Thank you for your question, Councillor. I will get back to you. We can give you some more information. I think the big context here is that we slowed down our inspections in the earlier part of the year during wave 1.
Okay.
As restaurants started opening again, we had certainly more work to do to help with the reopening in a safe way. But we have had to cut that back again. So we just do not have the same capacity to be doing all the inspections that we're normally mandated to do, and I think that's part of what I need to convey to you as the board is that some of our expectations under the accountability agreement will not be met, and I've reported on that as well to the Chief Medical Officer of Health. But in terms of how much we helped with reopenings and the number of inspections there, I can get that information for you.
And if I may ask you, because we've been asked in the rural area, and you just said yourself, we have to, we can't be just all consumed by COVID. There's other health and safety concern when it comes to the rural water testing. As you know, we have postponed it since the pandemic. I'm hoping at some point we have to come back because that's a very important function for the rural area. They all depend on their water. So somehow I need you to give it some consideration. I'm not saying we should do it tomorrow or next week, but just give it some consideration. That's a very important function out of public health that's in the rural area, not necessarily just in my area, but right across the city. As we all know, the city of Ottawa, 80% of it is rural. So I would ask you to really consider that function and bring it back.
Will do. Thank you.
Thank you. Thank you.
Thank you, Member El-Shantiri. Any other questions? Okay, so we need to receive Dr. Etch's verbal report. Received? No dissents? Okay, thank you. And on item number 4, which we kind of jumped into, there's the following to vote on: that the Board of Health for the City of Ottawa Health Unit, 1, direct the Medical Officer of Health to prepare a budget for 2021 that reflects the resources required to sustain the COVID-19 response and critical public health services. 2, direct the Medical Officer of Health to develop recommendations to the Government of Ontario that would seek to address systemic issues that have been brought to light as a result of the pandemic response to date. And 3, receive for information the evaluation report and supporting documents on the public health system evaluation and lessons learned from the first peak of COVID-19, prepared on behalf of the Council of Ontario Medical Officers of Health, attached as document 1. So can we carry that? Any dissents? No, thank you. I'm just going to check with Deanne. Deanne, is that those 2 items taken care of then? Everything we need to vote on?
Yes, Chair, we can move to the procedural matters at the end of the agenda.
Thanks very much. I'm going to call on Member Cloutier for the motion to adopt reports then.
Certainly, Chair. Merci beaucoup. Be it resolved that the presentation by Cameron Love on behalf of the Champlain COVID-19 Response Committee on Partnership and Readiness, the Chair of the Board of Health verbal report, the Medical Officer of Health verbal report, and the reports titled Update on COVID-19 and Next Steps, Ottawa Public Health Strategic Plan for 2019-2022, Year 1 Refresh, 2020 Operating Budget Q2, Board of Health for the City of Ottawa Health Unit Status Report, and Delegation of Authority, contracts awarded for the period January 1st to June 30th, 2020, be received and adopted.
Carried. Okay, no dissents? Thank you. Are there any motions requiring suspension of the rules of procedure? No, thank you. Are there any notices of motion for consideration at a subsequent meeting? Okay, thank you. I'm going to ask Member Kuche to move the confirmation bylaw, please.
Merci. Il est résolu que le règlement de ratification numéro 20, trait d'union 4, un règlement municipal du conseil de santé de la circonscription sanitaire de la ville d'Ottawa ratifiant les délibérations du conseil de santé d'Ottawa lors de sa réunion du 21 septembre 2020 soit lu et adopté.
Thank you very much. Merci. Carried? Any dissents? No, thank you. And adjournment. Our next meeting will be November the 2nd, 2020 at 5 p.m. Thank you all. It's been a long night. Lots of good discussion, lots of good questions, covering urban, suburban, rural, and everything on between. So much appreciated for that. And I think we got some good information out tonight. And the discussion is always very much appreciated.
Thank you.
And there is, sorry, one more thing I have to mention. Remind any media who may still be watching this meeting on the YouTube live stream, we will have a Zoom media availability 15 minutes after adjournment. This replaces the post-meeting media scrum that would normally happen after in-person meetings. If not already registered, media representatives wanting to participate can email ophmedia@ottawa.ca. Thank you very much, everyone.
Good night, all. Keep up
Thank
the good
you.
work.
Good night.